get a.
And I'm muting all of you. If you, when you are talking, you can unmute from your end. So a very good evening and a warm welcome to all the doctors present here in this clinic session. Team Planet is very proud to be a part of this event as a digital partner. Planet is India's largest live digital CME and doctors-generated medical content platform. So here is a short glimpse of Planet. Thank you so much all for your patience. You can always find us on Google, www.learnit.com. You all are invited to visit our site to enjoy lots of live sessions which are conducted by eminent speakers across the globe. We have MedWiki services, which is medical Wikipedia for doctors. So without further delay, now I would like to hand over the session to Professor Anin and Kutti sir to start with the scientific session. Over to you, sir. So please unmute from your end.
Namaste, sir. Shall we start? Please, Namaste, sir, you are mute. Please unmute.
Yeah.
Can we start?
Can we?
Can we start?
Yeah.
Okay. So good evening, all. I welcome the President of Kerala Orthopedic Association, Dr. Ramakrishnan S, for the welcome address.
Thank you, Anin. Good evening to all of you. We have an array of dignitaries, all senior faculties and professors who are going to guide today's session. And I personally think that this sort of monthly webinar CME has come to stay, and it has been a wonderful initiative from the part of OASIS, especially Professor Anin Kutti and Dr. Raghav Dutt. And I think it's a wonderful thing. And it also gets us to get knowledge while sitting at our own house or clinic. That's a wonderful thing. And let me first of all welcome the President of OASIS, Professor Selvaraj, and also Professor Anin Kutti, who is also the Secretary General of OASIS, Dr. Vasudevan PN, who is the Vice President of OASIS, and myself, Dr. Ramakrishnan, President of the Kerala Orthopedic Association, Dr. Anthony Topil, who is the Honorary Secretary of Kerala Orthopedic Association, and Dr. Jiju, who is also the Honorary Treasurer of KOA. And so this type of CME has been coming in rotation, and this month's CME is being organized by the Kerala Orthopedic Association. So without much, and I have personally selected this topic of rheumatology because I still find in my clinical practice that we orthopedic surgeons miss a lot of them in the early stages, because we are more probably concerned about the surgical aspects only. So the clinical, I still feel that especially the rheumatoid arthritis is one of the important pathologies, and it has to be diagnosed very early in its course so that you can manage them very well. So we'll go on to the medical aspects of the rheumatology. I'll hand over the session to Vishad so that he will introduce his colleagues and go along with the medical aspects. Vishad, please.
Namaste, sir. We'll have the inauguration and then.
Okay. Then we.
So I call upon President OASIS, Professor Selvaraj, sir, to inaugurate this ICL.
Over to you, sir.
Good evening, everyone. Secretary General of OASIS, Dr. Anin Nambikutti, the President OASIS Vice President from Kerala, Dr. Vasudevan, President of KOA, Dr. Ramakrishnan, Honorary Secretary of KOA, Dr. Anthony Joseph, Honorary Treasurer of KOA, Dr. Jiju, esteemed faculties and delegates. I'm very happy that KOA has chosen a very good topic. As Dr. Ramakrishnan was telling, rheumatoid arthritis is not very uncommon. We tend to miss it so much. And the topic itself, of this ICL itself, the current trends and recommendations in medical management and arthroplasty, because we must know when to stop giving drugs and when to take up the patient for surgery. and you cannot be treating a case which is to be taken up for surgery with drugs. So everything, there is a line has to be drawn. So definitely, I'm sure that this ICL will definitely throw light on the aspects, various aspects of rheumatoid arthritis and how we manage medically and when to take up for surgery. It's a very good topic. I congratulate KVA for taking up this interesting topic. I am happy to inaugurate the OASIS ICL. Thank you.
Thank you, sir. Aneen, over to you.
Yeah.
The Secretary General's a few words from you.
Yes. Good evening, all. Respected President OASIS, KOA, Secretary of KOA, senior faculty. I think Ramesh sir has taken a lot of pain because I think he has started this work of coordinating this 6 months back after the ICL of Kerala, which was previously organized from Kozhikode. So I think he would have arranged every topic in that manner, and I think he has medical specialists and the surgical specialists to talk to us. And I am not delaying. I congratulate Kerala Orthopedic Association for taking up this topic. And over to you, sir. I think we can call Honorary Secretary of Kerala Orthopedic Association, Anthony Joseph Topil, for a few words.
Dr. Anthony, please.
Thank you, sir. Respected President of the OASIS, Professor R. Selvaraj, Secretary General of the OASIS, Professor Aneen, Vice President Dr. Vasudevan, our own KOA President Dr. Ramakrishnan, Treasurer Jiju, esteemed faculty, and my dear friends. Rheumatoid arthritis has always been a dilemma, as Dr. Ramakrishnan has already mentioned. It has always been a dilemma to the practicing orthopedic surgeon. And I believe this OASIS ICL will go a long way in giving clarity to the treatment protocol of rheumatoid and other inflammatory arthritis. I should take this opportunity to congratulate the present office bearers of OASIS, especially my close friend, Professor Aneen, in organizing such webinars on a very regular basis. Now, let me also take this opportunity to everyone who is attending this webinar to invite you to the OASIS TraumaCon to be conducted on the 22nd of May at Calicut. So, not taking much of your time, thank you, and continue and enjoy the webinar. Thank you.
Thank you, Anthony. I think we can go to the academic session.
Yeah.
Sir.
I invite Dr. Vishad. Actually, I have asked Dr. Vishad, my good friend, to coordinate the medical aspects, and my friend Dr. Bimal to do the orthopedic surgical aspects. So over to you, Vishad, for briefly introducing the faculties and let them proceed with the talks.
Honorary President Dr. Selvaraj, Secretary General Professor Aneen, President KOA Ramakrishnan sir, and Secretary KOA Dr. Anthony. It's been actually a great privilege for us to share this platform with the orthopedicians, because we say gastroenterologists have gastrosurgeons, neurologists have neurosurgeons. So whom do we have? And the answer, I think, is orthopedicians. So we share quite a bit of patients between the two of us. The problems we face are identical. Our perspectives may be different, but often our patients land up with either of the specialties with similar complaints. So I think this is a very good initiative from the Kerala Orthopedic Association and OASIS to actually bring us to your platform and give an opportunity to share our thoughts and receive from you your own thoughts about the diseases that we so closely share. So rheumatoid arthritis, as you know, is one condition which has actually dramatically changed the landscape of treatment in the last couple of decades. From a disease which was probably considered to be untreatable or difficult to treat, it is something which we would say that it is fate that the patient will have to live with it. Now, I should say that it's an eminently treatable disease. And today we are dealing with the different aspects of this condition. I'm proud to present our faculty from rheumatology side. We have a very eminent panel of rheumatologists. Dr. Sajjan Shenoy, he is a consultant at KMC Manipal, Mangalore, and he's a very enthusiastic and rheumatologist and a very excellent speaker. So he will deal with the approach to polyarthritis. Dr. Paul Anthony, who is Associate Professor of Medicine at Amala Hospital, he will talk about diagnostic aspects of rheumatoid arthritis. And Dr. Padmanabh Shenoy, whom you are all very familiar with, I'm sure, will talk to you about he's a consultant and medical director at CARE, and he will talk to you about the management aspect. And I'll be talking and speaking about the long-term complications. So our speakers, Dr. Sajan and Dr. Shenoy, myself are trained from STPGI, and Dr. Paul Anthony is trained from JIPMA. So I hope that we'll have an excellent knowledge sharing session in the next couple of hours. Over to you, Damarshan. Or shall I carry forward?
No, yeah. Dr. Sajan.
I think we'll start off with the first topic, which is about the approach to polyarthritis, differential diagnosis, and I invite Dr. Sajan to start off the session.
Good evening to all the people who are gathered here. I'll just start the share. Can you see my screen?
Yeah.
Yes. Okay. So my thanks to all the office bearers of OASIS and Kerala Orthopedic Association, and also to Dr. Vishal for having given me this opportunity to speak on this topic. So when we talk about rheumatoid arthritis, our main crux of the discussion today is going to be rheumatoid arthritis. Now, before we reach to a patient with a definitive diagnosis of rheumatoid arthritis, we usually have to swim across an ocean of different reasons for polyarthritis, which often we get stuck there, and we often tend to drown there in this ocean of polyarthritis, and often the diagnosis of RA is wrong. So getting a diagnosis of RA right is the first step towards treating rheumatoid arthritis. So that would be my way of looking at it. So an approach to a patient with polyarthritis is equally important. And I will talk about the clinical evaluation as to how to go about this. A further detailed explanation as to how to diagnose it using autoantibodies and so on will be discussed by Dr. Paul. So polyarthralgia as a symptom is very common. We all have seen that. So we are professionals dealing with musculoskeletal problems. So almost all patients who walk into our clinics probably have these kind of symptoms with joint disease. But we know that not all of them have serious disease. So that's for sure. Not all of them will go on to develop joint damage. So the crux of the issue is, when such a patient comes, in whom do we suspect a serious underlying disease? In whom is it going to be RA or some other disorder? And which of these patients will require investigation and treatment in the long run? Now, first we need to clearly define what is polyarthritis or polyarthralgia. Now, difference between arthralgia and arthritis is fairly straightforward. Arthralgia is just joint pain. Arthritis is an inflammatory joint problem, a synovitis. So if you look at the definition, it is polyarthritis, means synovitis affecting more than or equal to 4 joints. Anything less than that would be called oligoarthritis, and single will be obviously monoarthritis. Now, in the world of
Dr. Sajan, I think your slides are not moving for the others.
Is it?
Yes.
But is it moving now?
No, it is not moving. It is in the not in the slideshow also. So you just yeah, now it is moving, but it's not in the slideshow. You just put in the.
Let me try again. Is this now moving?
Just unshare and then share again.
Okay, I'll stop sharing.
Yeah.
And then I'll put it back again on screen share. Okay, is it okay now?
No, but it is not in the slideshow.
Full screen slideshow.
It's not.
So you can do one thing. You can when you are sharing your screen, you share the entire screen, not the PPT one.
You are sharing that only that screen. Your whole screen is.
Let me try once more.
Two options are there.
Yeah, is it now seen as a full screen?
No, sir.
No.
Now you just make it full screen.
Yeah, this is full screen.
No. For us, it is not full screen, sir.
All right. Okay. So what I'll do is I'll just stick to this screen. Is that okay?
Yeah. Okay. Now it is moving. Just see, it is moving.
See this?
Yeah. Now it is moving.
Fine.
It's okay.
Okay. So I'll just stick to this. No problem.
Yeah, no problem.
So we can just focus on the,
Okay.
the slide part.
Okay.
So I was talking about the definition. So now when we talk about definition, the definition of poly is joints being affected being more than or equal to 4 in number. One important difference here is in children in the juvenile idiopathic arthritis group or in the pediatric age group, where the age definition is less than 16 years of age at onset, the cutoff is 5 joints. Why is there a definitive difference like this? We do not know. It is possibly that the literature has been generated by the pediatric rheumatologists and the adult rheumatologists were never talking to them in the first place. So that might have been a reason, but that's hardly of any consequence in the differential diagnosis or in the clinical workup. But this difference does exist. So another important definition we need to look at is the time definition. Any arthritis or polyarthritis which is less than 6 weeks will be categorized as acute, and something which is more than or equal to 6 weeks will be categorized as chronic. So this is the definition which we need to work on when we talk about differential diagnosis. Now, when we talk about a patient who has come to you with multiple joint pains more than or equal to 4 joints involved, the important questions that need to be answered are these 4. Is it articular or periarticular? Is the joint pain inflammatory in nature? Is it part of a larger systemic syndrome, which I would put it as, red flags? And then what clues are there to narrow down differentials for us in the clinic? So these are the 4 important questions that need to be answered, which will then lead you to a definitive diagnosis of a patient with polyarthritis. Now, the first 2 questions, that is whether it is articular or periarticular, and whether the joint pain is inflammatory in nature, are the absolute basics. Now, one would presume that, in an audience which is predominantly practicing orthopedician, these kind of basics are very clear. But then I always tell my, students when I take classes that the best time to revise your basics is before the exam, and the next best time is now. So let's, take a couple of minutes to just important points which will help us to figure out whether this is articular or periarticular, inflammatory versus non-inflammatory. Because the main issue is that majority of patients who actually come to us with joint pains don't have inflammatory issues. Majority of them are non-inflammatory multiple joint or multiple area issues. So we need to be absolutely sure before we go into a diagnosis of polyarthritis, whether it is actually inflammatory synovitis or not. So from that viewpoint, articular pains are usually very well localized, and the description of pain will be very well localized to the joint in comparison to, let's say, regional joint syndromes or regional pain syndromes or neurological pain syndromes, where the description is more diffuse. It is not well localized. So in joint problems, usually it is very well localized. Pain on specific maneuvers in patients who have inflammatory joint pain or joint involvement, the pain is present in all directions of movement of the joint, what we call as universal stress pain, in comparison to periarticular joint pains, which are usually only on particular maneuvers. The classic example goes in the shoulder, isn't it? There's typical, the raise test or the drop test, which are typical for supraspinatus tendinitis, in comparison to shoulder synovitis, which will have stress pain in all directions of movement. So this is a classic example. Passive versus active movement. In patients who have periarticular problems, active movements are painful. Passive movements are often not painful, not always, but often. But in patients who have articular problems, both active as well as passive movements are likely to be painful or limited. Finally, we have the swelling. If there is an effusion in the joint, then obviously the location has to conform to the anatomical location of the joint involved. So that is very clear. So these are the basics which we always discuss about. So in comparison, the common causes of non-articular pain, because if it is articular, yes, then we move on to the next section. But if it is non-articular multiple area pains, then the most common thing which you would actually encounter in your clinic is actually fibromyalgia. And it is often more in middle-aged women with widespread pain associated with mentation, memory, and sleep disturbances. And often they have features of irritable bowel. In these situations, instead of running behind inflammatory joint disorders, we need to actually look at other metabolic disorders like metabolic bone disorders. Always go for an alkaline phosphatase evaluation, Often we miss calcium, phosphorus disorders, parathyroid disorders, and so on, because we never bother to look at the alkaline phosphatase. Creatinine, because CKD, that is chronic kidney disease with secondary bone disorders like the renal osteodystrophies, tend to present with multiple areas of pain, but not really restricted to the joint. So a serum creatinine testing is in place. Similarly, as usual screening for hypothyroidism and for rarer disorders like leukemias, especially in children, because they will present with multiple areas of pains, which they will complain as joint pains, but then it is mainly periarticular and especially bony. So in such situations, a simple total leukocyte count or a Ferris wheel smear will definitely help us. Occasionally, you may see patients who have severe iron deficiency anemias or severe vitamin E deficiencies who do complain of pain in multiple areas. But then, the literature surrounding this is, sketchy. But then real life clinical practice, we do see that these patients tend to complain of multiple joint pains. Then another important one, for example, BJHS. Today itself, I saw 3 patients who had joint hypermobility syndrome, often missed because we don't actively look for it. It has a prevalence of almost 5 to 8% in our population, which is pretty big. Let's compare that to rheumatoid arthritis, which has a prevalence of about 1% in the population. So this is 5 to 6 times more common than RA. So this, you are likely to see this more than RA. And we have something called as the Baton scoring to diagnose this, more than out of 6. I have given a small printout which shows the various steps that you do to use the Baton scoring. Essentially, it has got to do with hyperextensibility of the MCP joint in figure number 1. It got to do with the thumb extension. It has got to do with elbow hyperextensibility, knee hyperextensibility, and then finally lumbar hyperflexion. So if the score is more than 6, each one gets 2. So 2 into 4 is 8 plus 1, 9. So if it is more than or equal to 6, then that diagnoses BJHS. And often the treatment will be good muscle tone exercises to maintain their muscle tone and refrain from activities which promote hyperextension. Typically, these kind of patients will be champions in yoga or champions in gymnastics. So you need to, bring down their enthusiasm and tone them down, saying that, you stick to the usual rules of the game. So BJHS, not to be missed, it's a very simple, easily diagnosed. Often we do see psychiatric disorders. So many patients will keep coming and telling you that I have so many problems, but then clinical examination looks normal. Then obviously a psychiatric disorder has to be considered. And in which case you basically need a good psychiatry specialty consult. It may take some time to, convince the patient that you need one, but then ultimately that's what they are going to get relief from. Finally, we have localized pain disorders. Now, clearly, localized pain disorders are often one or a couple of areas, but then occasionally you do see patients who have got 3-4 areas, different area involvement, but all of them are actually localized pain disorders. And all of these syndromes, that is the epicondylitis, tenosynovitis, enthesitis, and so on, we all see on a regular basis. So this crowd clearly knows that. So once we are out of this whole bunch of periarticular problems, now let's focus on the articular problems. Now, if we are really convinced that the patient has an articular problem, the next question is whether it is inflammatory or not. These are very important points which I need to keep highlighting for any audience, be it rheumatologists, orthopedics, general practitioners, or MBBS students. Ultimately, inflammatory arthritis is often a clinical diagnosis. So stiffness, which involves early morning stiffness and after rest, is very important. And often it will last for more than 30 minutes, usually lasting for hours, a couple of hours, 3 hours, and so on. In comparison, in osteoarthritis and other degenerative disorders, it is more of a gelling phenomenon, where the stiffness is often less than 15 minutes. This is a very important difference between a degenerative arthritis versus inflammatory arthritis. Second, limitation of movement on examination. If there is a limitation of movement of the joint and you have considered and ruled out periarticular problems and muscle contractures, then limitation of movement almost always tells you that this problem is articular in nature. And then swelling, we discussed that it has to be limited to the joints. So now localized growth disturbances also can tell you and definitely pinpoint to you that the problem is in the joints. For example, limb length inequalities. Now let's say that this child with the shown in the panel B has a limb length inequality. The problem could be in either joint, either limb. The answer to that will lie on history. If the problem has been long standing, and the shorter limb is likely to be the problem limb, whereas if the problem is recent, then the longer limb is likely to be the problem limb. So you need to go through the history and get this. But then we have clear-cut features like retrognathia or micrognathia. We tell you that the problem is definitely articular. And in such situations, a non-inflammatory arthritis is usually a straightforward diagnosis. A non-inflammatory acute polyarthritis is often seen in only hemoglobinopathies and amyloid arthropathies. Now, in an orthopedic practice, usually you're not probably going to see these patients because these patients are likely to have previous histories of hemoglobinopathies. First presentation with this, unlikely. Chronic non-inflammatory joint problems, clearly we see them on a regular basis, osteoarthritis, so there's no need to talk much about that. Now, our interest and the main topic for today is the inflammatory polyarthritis. Now, we spent about 6-7 minutes on the non-inflammatory arthritis and the periarticular problems because they are extremely important, and it is very likely that we will see them in more numbers than the patients whom we are going to discuss next. Now, in the third step, we said that if there is an inflammatory arthritis, then the next step is to look for systemic features. Extremely important. Often people miss this. So are there extra articular features? You need to ask the patient this. Many patients would not even probably volunteer this information to you. For example, fever. Now, fever, most probably many would ask, like septic arthritis differentials and all that. But then other than that, many other things, for example, skin rash. How many of you would ask a patient with polyarthritis, do you have dandruff? Do you have psoriasis? Do you have skin rashes behind your ear or under your breast or in the groin region or in the axillae? How many times have you asked this question? You need to ask this question because skin rash often often tells you that there is some other systemic disease going on here, often psoriasis or some other connective tissue disorders. The same goes for oral ulcers. Oral ulcers, as we all know, is often a part seen in lupus and other connective tissue disorders. They can also be seen in Behçet's disease and so on. Cough and breathlessness tells you that there is a respiratory involvement, which then becomes a multi-system involvement. You need to look into it. Weakness and neurological symptoms, weakness of facial muscles, weakness of the eye muscles, weakness of the limbs also tells you that there is a neurological problem going on here. It is not joint limited. Similarly, hair loss. Hair loss in the sense we are talking about either diffuse alopecia or alopecia which is scarring and limited to certain areas of the scalp. Either way, hair loss is a very important sign. And then any other systemic involvement. For example, a red eye. The patient may not tell you that I had a recent red eye, I had to see the ophthalmologist, turned out to be uveitis or turned out to be scleritis. So these kind of other systemic involvement gives you a pointer that the patient has something more sinister than simply a joint involvement. So I have listed some of them for you. For example, let's see, connective tissue disorders like SLE, MCTD, which is mixed connective tissue disorder, systemic sclerosis, inflammatory myositis, vasculitic syndromes like Wegener's, EGPA, that is Church-Strauss, our erstwhile Church-Strauss. And then, of course, we have other rarer diagnoses like malignancies, leukemias, lymphomas, and so on. Now, our pointer, I'll just put up few slides just to bring out the point that polyarthritis, when a patient has polyarthritis, always look for other systemic symptoms. Now, let's see this patient, for example. We have a photo here who has polyarthritis, and also she has many things going on here. It is very clear in an audience where we could interact. I would ask them, what are the things that you could see? Most of them will definitely point out the malar rash, which is sitting on the malar area and in the nasal area. And then there are many other things. For example, look at her eyes. You have a drooping eyelid on left side or maybe a Bell's phenomenon on the right side. Now, whether it is Bell's phenomenon on the right side or drooping of the ptosis on the left side, you need to figure out by clinically examining her. But one thing is for sure, that there is a neurological deficit here. Also, probably you can argue that she has a mild alopecia. You can see her scalp hair, which is odd for women. So put together, our patient has polyarthritis, not just polyarthritis. Our patient has polyarthritis. She has a neurological deficit. She has a malar rash and she has an alopecia. Now we are veering way off the track of a clear-cut, simple rheumatoid arthritis. This is a classic patient with SLE, lupus. So this is not to be missed, and this is not rheumatoid arthritis. This needs further workup, further evaluation to get to the depth of this and get an appropriate diagnosis. Now let's see another patient who has come to us with polyarthritis. So clearly he has joint pains, but other than that, he has also this picture on his leg. Now, what is this? This is basically palpable purpurae. Now, palpable purpurae often are a feature of vasculitis. Which vasculitis? We do not know. That depends on his other systemic involvement and other evaluation. The classic commonest thing which you would see like this is the classic HSP, Henoch-Schwann purpura, now renamed as IgA vasculitis. Either way, it is a vasculitic syndrome. Then we have much more sinister vasculitis like Wegener's, which we just talked about, Church-Strauss syndrome, and so on and so forth. For that matter, this can simply be a drug-induced rash and related serum sickness-like features. So ultimately, what it points to you is that there is something else going on than just polyarthritis. So this we would classify as a vasculitic syndrome, needs evaluation. This is not RA. Now we have another patient who also has polyarthritis and who has come with this picture. Now anybody can identify this. Let me give you about 5 seconds to think what this is. I will also give you another clue. This patient has got weakness of the muscles. She is unable to, abduct her shoulders beyond 90 degrees, and she has difficulty in getting up from sitting position, not due to the joint pains, but because of muscle weakness. Now that brings us to the whole gamut of myositis spectrum of disorders. So this patient has this classic feature of dermatomyositis, the periorbital involvement and the palpebral involvement, which we would classify into the dermatomyositis spectrum of disorders. So in such patients, we'll have muscle weakness related to inflammatory myositis, joint involvement, skin involvement, lung involvement, and so on. Now the important point to pick up here is that the patient has got a dermatological involvement as well as a myopathic involvement. So which brings us way away from the classic simple polyarthritis that we see. Similarly, we have another patient who also has polyarthritis, and then when we ask him to lift his both dorsum of feet, this is what we get. Now clearly he has a left foot drop. Left foot drop is not explained by a joint involvement. It has to be neurological involvement. So this again goes towards a gamut of other disorders which have multisystemic involvement. Now what is it? We have to evaluate on a systemic basis. It could be a vasculitic disease. It could be connective tissue disease. It could be RA, a rheumatoid arthritis patient who has subsequently developed a complication of vasculitis, what we would call as rheumatoid vasculitis. But then again, it alerts to you the possibility that this is not the simple garden variety rheumatoid arthritis. Keep your eyes open to all this. So ultimately, by doing all this, we are trying to fit our patient into one of these two groups. So if we have an acute, that is less than 6 weeks, or some may argue 12 weeks, either way, acute polyarthritis, often it will be viral, serum sickness, or drug induced, which are usually clearly determined by a history, not by any particular evaluation. If the patient tells you, I took a sulfa drug and then developed this, drug induced arthritis, you know that, right? Early onset of CTD. If it is an early onset of CTD, it is very likely you will see some of the features that we discussed right now. Now in rheumatic fever, again, you will have other systemic involvement. In palindromic and RS3P, it is very likely that they'll be limited only to the joints and the tenosynovial compartments. Let's not discuss about them because they are very rare. Now putting across the rest of the part, if you have chronic polyarthritis, then we have RA, which is top of the list, but it is actually a diagnosis of exclusion on clinical basis. So if you have MCTD, lupus, scleroderma, juvenile idiopathic arthritis, the patient is likely to have much more going on systemically than simply in the joints. Now, a classic example is Still's disease. You would have heard about Still's disease. A Still's disease patient has got florid polyarthritis, but then they also have persistent fevers. They also have lymphadenopathy, organomegalies, and many other things going on in the skin and so on. So they are not easily missed. So from an acute polyarthritis point of view, more than 60% of them will resolve spontaneously by the end of 6 to 8 weeks. We don't need DMARDs. We don't need any other hi-fi things to be done. We just need to recognize them that there's nothing else going on here. And then we would probably just give NSAIDs, or if required, a short course of steroid and wait. Because mostly all of them are viral, serum sickness induced, or drug related. How to predict chronicity and erosive arthritis? Yes, that we will discuss in the topic of RA. Presence of extra-articular features, which we just discussed, predict that this is going to be chronic and something else is going on, and seropositivity to the antibodies. Now, chronic arthritis is more important for us, chronic polyarthritis. Why? Because it can be due to many causes, most of which we have delineated causes today. Some of them are very acutely progressive. For example, vaginous, a patient presents with polyarthritis, rapidly develops capillaritis, hemoptysis, respiratory failure, death. Now, that's not what we want in a patient who walks into us with polyarthritis, but it can happen and we need to pick it up. Some are chronic and can cause serious organ damage like lupus, in whom we can have renal failure and so on. But almost all of them can cause permanent damage. And we don't want a perfectly looking good knee end up with a bad secondary osteoarthritis and then ending up with a very bad disabled life. So we don't want that to happen. So for that reason, we need to understand that we need to categorize these patients with polyarthritis into clear-cut diagnostic categories. Rheumatoid arthritis is ultimately the clinical diagnosis, where we have symmetrical chronic polyarthritis with no other systemic involvement. Extremely important to understand this. Secondary systemic involvement can occur in long-standing untreated cases. For example, an RA patient has got 10 years of disease, then develops a foot drop or a mononeuritis multiplex. Fair enough. Rheumatoid vasculitis is a possibility. But a patient who comes with polyarthritis for 2 months, develops mononeuritis multiplex, foot drop, and so on, is not rheumatoid arthritis. The role of RF and anti-CSP will be discussed in further detail. So the whole point is that an appropriate diagnosis and early therapy is the key for a good outcome in such situations. And the take-home message for the day is that often most polyarthralgias are non-articular and non-inflammatory in nature. If it's a true chronic polyarthritis, then RA is to be diagnosed only after other diagnoses have been considered and ruled out, in which clinical evaluation is often the most important key for us. Thank you.
Thank you, Sajjan. I think he has covered, he has given a very comprehensive overlook about an approach to polyarthralgias. I think we have decided that we'll have 2 sessions together and take questions of the 2 sessions together. Is it not, sir? Sir, Namaste, sir. Yeah. So now let me invite Dr. Paul Anthony. He's discussing about the diagnosis of rheumatoid arthritis, autoantibodies and imaging. Dr. Paul, as I mentioned, is an associate professor at Tamila Medical College, and he's a versatile speaker. Over to you, Paul.
Am I audible?
You're audible, Paul.
So is the screen also in full screen?
Yeah.
So I'd like to thank the organizers of OASIS and Vishad for inviting me for this talk. So I'll briefly cover about the diagnosis of rheumatoid arthritis. The criteria, imaging, and autoantibodies is the topic allotted to me. So as you all know, rheumatoid arthritis is a chronic deforming polyarthritis. And you know that if you don't treat it properly, or if you don't treat it sufficiently early, you're going to end up with hands like this, which has to be managed in a very, very difficult way. But it's all not very bad. You can see that this is a seed which is now growing into a plant. So this represents the various stages of rheumatoid arthritis. You can see the prearticular phase, the arthralgia, the initial clinical phase, and second and third clinical phase. So we now know that if we are able to intervene at these very early stages, we will be able to control the disease in a sufficient manner so that you don't see the pictures of the big one which you've shown in the beginning. So that it represents that why the early diagnosis of rheumatoid arthritis, especially if possible, even in the arthralgia phase, even before the florid synovitis develops, we can make much more difference in the life of the patient. There is some summary of some of the studies in which they've done very minute intervention. You can see the first trial is just a single intramuscular injection of methylprednisolone, and the follow-up was after a year. You can see that did not show any effect. But when you see the 3 injections, the second study, you can see that there is some difference. So just by even giving very short doses of steroid itself, they were able to produce a lot of effect in the outcome of the patients. So this truly shows us that if we are able to intervene at early stages, we can make huge difference in the lives of the patient. So this just shows that early treatment in undifferentiated arthritis prevents the RA onset and progression. So the interest was generated in the early 2000s that if we can diagnose it even in the undifferentiated stage, we can make a huge difference in the patients. So how do we do that? So in the initial ages, we had the 1956 criteria, which I'm not going to go through. Subsequently, we had the 1987 criteria, which was a criteria which was developed after studying a lot of patients with established rheumatoid arthritis. So these were patients who had arthritis for 7 years or more. And the criteria was based on that. So this included morning stiffness, arthritis of 3 or more joint areas, arthritis of hand joints and symmetric arthritis, and it had to be present for more than 6 weeks before including in the criteria. And some of the other factors like rheumatoid nodules, it's a late manifestation. So we should not wait for the rheumatoid nodule to happen. And the presence of rheumatoid factor could be seen in 70 to 80%. But if we relied only on the rheumatoid factor, we tended to miss 30% of cases. Again, radiographic changes should not happen in patients. So this was the problem with the old criteria. And it was a very good criteria as far as picking up established cases. But when it came to picking up undifferentiated arthritis or when it came to picking up the early RA, it used to fail a lot. So because of that, the American College and the European Union, they sat together and they came out with a new criteria, which is now being followed. Now it's 12 years old now. So this is a criteria which basically looks into the clinical aspects like the type of joint involvement. And we all know that rheumatoid is a disease which tends to favor the smaller joints. So if you have more of the smaller joints involved, smaller joints include the MCP joints, the PIP joints, and also the wrist. And it excludes the carpal metacarpal joint, the distal interphalangeal joint, and the first metatarsophalangeal joint, which can be involved in OA. It also includes the serology. It has given importance to the rheumatoid factor and introduced anti-CCP. And you can see that if the titers are high, it shows more scores. And the acute phase reactants like ESR and CRPS are also included, and the duration of symptoms. But I must now say that these criteria are basically used to include patients in studies. It should not be used for your diagnosis. And this criteria is, although it is very specific, sensitivity is, sensitivity is very high, specificity is low. I'm sorry about the earlier statement. Very highly sensitive. So supposing you have a viral arthritis, which usually resolves in 6 weeks, and you have a patient who has not resolved in 6 weeks, and the patient is put under this criteria, you can see that more than 6 weeks, a score of 1. And if the patient has inflammatory markers elevated, again, an additional score of 1. And by chance is an elderly patient with low positive rheumatoid factor, which is falsely positive, then again a score of 2 is added, so it becomes 4. And the small joints are involved, a score of 5 is added. That patient also satisfies the criteria. But we are not dealing with the rheumatoid, we're dealing with the viral arthritis. So that's the problem when we use the criteria strictly for a clinical diagnosis. For diagnosis, we follow the clinical method, and criteria is used for homogenizing the population and for the studies. And this is a summary of the 2 studies which show that basically the newer criteria performs well as far as the sensitivity is concerned, especially in early disease, but it lacks for the specificity. So we may pick up more patients, and which there's a chance of over-treating rather than under-treating. Now coming to the next thing, that is the autoantibodies. We all know about rheumatoid factor. First thing I would like to highlight is it's rheumatoid factor, not RA factor. And it's usually recognized the antibodies against the FC portion of IgG. The usual antibody is IgM, but sometimes you can have IgG and IgA can also be there. It is not related to the pathogenesis of disease. It it is highly sensitive as far as established RA was concerned. But for for early disease, sometimes it used to lack the sensitivity. So sometimes you had patients who had RA and initially the antibody was negative and later on developed positivity. But it has highly specific, especially in high titers, the specificity is good, but in low titers, the specificity is really bad. And it can predict the severity of disease, those who are likely to have a rapid disease and extra-articular manifestations. You can see that these are some of the other rheumatological conditions in which the rheumatoid factor is possible. So that is what I said. RA, the rheumatoid factor does not mean RAF, it actually means rheumatoid factor. And even healthy people, elderly people more than 70 years can have positive rheumatoid factor in 10 to 25% of cases in chronic infections, pulmonary disease, malignancy. And it can also be negative in some of the rheumatoid arthritis, especially in the early stages. And even in the late stages, at least 20% of patients fail to develop the rheumatoid factor. And this should not deter you from making a diagnosis of rheumatoid arthritis. And it can be used mainly for the diagnosis of rheumatoid arthritis. We don't do repeat testing at all for rheumatoid arthritis, but there are other conditions like Sjogren's and cryoglobulinemia where this factor may be followed up for disease evolution. The next antibody is the anti-CCP or the ACPA. It started with recognizing that some of the serum of patients with RA had an anti-perinuclear factor, and it was diagnosed to be anti-keratin antibodies, subsequently profilagrin, and they found that if you cyclize the profilagrin, the recognition was better. So the ACP1, ACP2 test was nowadays whenever we do the ACP, we usually use the ACP2 test. And these are some of the other autoantibodies. Although we are not using it commercially in a big way, we know about some of us know about, seronegative rheumatoid arthritis. So if we apply some of these antibodies, we can find that some of these seronegative antibodies, especially antibodies like anti-carbonated B, may be recognized in patients who are apparently seronegative. So maybe over time, we are going to develop new tests which will make sure that all of our rheumatoid arthritis becomes seropositive for some antibody or the other. But at present, we need to just focus on rheumatoid factor and ACCP. Now, coming to the imaging, you know that RA is basically a synovial inflammation. So initially there will be synovial swelling, then there will be synovitis, and subsequently it will lead to pannus formation, which will involve the bone, leading to osteopenia. So these are the various findings which can be seen in various stages of RA. You can see that the soft tissue swelling, the periartical osteopenia, the marginal erosions, and joint space widening. So you know that these things are more likely to be picked up by an ultrasound or an MRI rather than a conventional X-ray. And over time, once you develop the radiographic changes, the bony deformities, the joint space narrowing, and the erosions, then the X-rays actually come in. So now we are more interested in picking up the early stages. So we should be doing more of imaging using the ultrasound and MRI, which is more widely available. So I'll show you some of the X-ray findings, I think, which probably all of us are familiar with. This is the earliest manifestation, that is a soft tissue swelling, which can be seen in the joints involved in this thing. And then you know about the juxtaarticular osteopenia, which can happen. And we all of us know about the erosions which start from the bare area of the bone, where the cartilage is thinnest and the synovium starts. And you know that there may be joint space narrowing, which is usually a uniform joint space narrowing, which differentiates it from an osteoarthritic process. Now, how do we apply that as far as ultrasound is concerned? So this is an ultrasound image. This is the metacarpal bone, and this is the proximal bone. And you can see that from the joint that arises the synovium. So this is an anechoic area where it's relatively appearing black, which shows the synovial fluid. It cannot be completely compressible. And this is the other, the two ways. You do it in the dorsal view, and you should do it in the lateral view, and you can find that it is persistently seen. So that make sure that in both views it appears, so that it's not an anisotropy or something which happens with ultrasound. Again, you can see here that there is fluid that's in an anechoic area, and there is a small hypo or hyperechoic area which can be seen. This is part of the synovitis. And when they apply Doppler, you can see that these areas where the synovial thickening happens, there is the increased Doppler signal, which shows that you're truly dealing with a synovial inflammation. Again, the use of the power Doppler. So even if you don't have a synovial fluid or a synovial thickening, the power Doppler can show that extreme inflammation which is happening in these areas, which would point that there is active inflammation going on where you need to involve, especially a patient who reports that there is some pain and you find no obvious swelling or no thickening. And when you do an ultrasound, you find that that there is a definite activity going on and you pick up these cases. Again, and we came to know that the RA not only affects the joints, but the tenosynovium. It has now been well established after the usage of ultrasound that you can see that the flexor tendon, around the flexor tendon, again you can see fluid around the flexor tendon, and in both views you can see, and again you can see the power Doppler showing extensive information around the tendon sheath, which shows that this is definitely an ongoing inflammation. Again, early erosions can be picked up in ultrasound. You can see the defects in the cartilage, and it is actually progressing, and you can see a huge defect which has usually progressed as the disease has progressed. Here you can see that this area is the inflamed area with the erosion, and you can see that there is a pannus with active synovitis ongoing around the site of inflammation, which shows both active inflammation and damage ongoing. So you can see the actual pathogenesis in evolution when you use an ultrasound to do that. And if you're fortunate enough to have MRIs, you can pick up bone marrow edemas, which is usually seen as a signal hyperintensity, especially in the fat sat images in the T2 weighted images. And you can see in the T1 images, you can see that there is a low signal areas. And if you see it in two views, that confirms the presence of erosions, which can be picked up much earlier as compared to the X-rays. And again, you can show this is the synovial thickening with increased signal, especially when you apply contrast. You can see that gadolinium enhances in these areas. Again, a repeat image of the same. So this is the EULA guidelines, which suggests that although we have not really actually included the ultrasound and MRI, we do encourage, especially in patients who are having a diagnostic dilemma. The patient has got some hand joint problems and the antibodies are negative, but you suspect inflammation. It would be worthwhile to look into an ultrasound or MRI. So whenever there's a diagnostic doubt, ultrasound or MRI can be used to improve the certainty of diagnosis. Or the level of evidence is only 3, and usually most of it's an expert-based evidence. And inflammation seen on MRI or ultrasound can predict progression to clinical RA later on. And it is superior to clinical examination, definitely. And it is superior to a conventional radiograph, especially if a conventional radiograph fails to pick up. And it has an independent, especially bone marrow edema in MRI, as an independent predictor of subsequent development of erosion. And these are patients whom you have to take very seriously and probably mount an aggressive response. And this is also not only in the initial stages, also later on if patient reports pain and you are fortunate enough to see a BME on MRI, this patient needs to hike up their immunosuppression to make sure that patient does not develop deformity or erosions in the future. So we know that criteria are useful basically for research. They should not be substituted for clinical, but it would be nice if the patient satisfies the criteria. And autoantibodies may predict the disease early. However, we have to be aware that even now there are certain groups who fail to develop the antibody positivity at any point of time. And if the antibody doesn't help you, then imaging is probably the next avenue, especially ultrasound and MRI with its now huge availability over the last couple of years. So with that, I come to the end of my talk. I'm open for some questions. Thank you.
Paul, we'll have the thank you for the very nice discussion on and comprehensive discussion on diagnosis. You've covered the various aspects, including autoantibodies, the upcoming role of imaging, which has been a game changer in early diagnosis. It has potential to be a game changer in early diagnosis. We'll have the questions at the end of all 4 sessions. So now I invite Dr. Patnav Shenoy. I think he's known to all of us here. He's one of the most famous rheumatologists in South India and India, the pan-Indian figures. So Shenoy will be speaking. He's medical director and consultant rheumatologist at Care Kochi, and he'll be speaking on management of rheumatoid arthritis. Over to you.
Thank you, Vishad, for the kind invite. And so I will be speaking on treatment of rheumatoid arthritis in 2022. So today when we are sitting, I will start with an index case, who is a 55-year-old female, who is a wife of a doctor. She is a seropositive rheumatoid arthritis for 6 months duration, and she has been on NSAIDs. She came to me in 2014. She was wheelchair bound, unable to walk. despite being on NSAIDs. She had a huge number of tender joint counts and swollen joint counts. And you can see the ESR was very high. So her DAS28 disease activity score was something around 7.1. So she had a very high disease activity. So what do we expect in rheumatoid arthritis currently? Now, in 1980s, it was a non-treatable disease because there were not many drugs. Only steroids were there, non-steroidal anti-inflammatory drugs, and gold was there. And they had their own adverse events. And they suffer from severe pain because none of these drugs are very effective. And most of the patients used to stop their working, even if they are most famous, most influential. They couldn't get any much treatment. And majority required surgery, joint replacement surgeries. And remission was very, very rare. Unless it was natural remission, remission could not be achieved in most of the patients. From that, last 30 years, remission, people expect complete remission, normal working, at minimal cost, and preventing surgery is possible. And now we are talking about cure or drug-free remission. So see the drastic change over the last 30 to 40 years in the management of rheumatoid arthritis. And how can we use the drugs which are currently available to achieve the current day expectation, to have a normal working to almost all the patient and have at a minimal cost. So what are the drugs available? Are disease modifying anti-rheumatoid drugs can be classified into conventional synthetic disease modifying anti-rheumatoid drugs, biological DMARDs, and targeted synthetic DMARDs. So I will cover one by one. Conventional synthetic DMARD are the most useful drugs, has been in the market for more than 30 years. They consist of methotrexate, hydroxychloroquine, sulfasalazine, leflunomide. All the participants have heard and used these drugs. This is biological DMARD. They are in the arena for last 2 decades. Anti-TNF, anti-IL-6, rituximab, and abatacept. And targeted synthetic DMARDs are the new kids on the block. They have been available for last decade, and they are available very cheap now. And I am sure you all of us must have heard of tofacitinib and baricitinib, which are available in the country and have used. So coming to the conventional synthetic DMARD, hydroxychloroquine is the most commonly used, least toxic, and least effective. It is the onset of action is pretty slow. It takes around 3 to 6 months to start acting. And it's a very safe drug, very, very safe drug. Although it has been earned a lot of bad reputation, which it doesn't deserve, telling that it is a eye toxic and it has a lot of retinal toxicity. Retinal toxicity is extremely rare, less than 1%. Major toxicity, what is seen is skin pigmentation and GI toxicity, which is seen in certain number of patients. So chloroquine is a very mild DMARD, and slow acting. Sulfasalazine is a very good drug again, but it has to be given at a specific 2 to 3 gram dosage. But the issue with sulfasalazine is, in some patients, it can cause severe hypersensitivity, and sometimes it can result in death. Another issue is myelosuppression and oligospermia, especially oligospermia in males is a issue with sulfasalazine. Methotrexate is one of the once-a-week pill which has changed the lives of millions of people. Very cheap, very affordable, but has to be given in stiff doses, 20 to 25 milligram per week, and very strictly has to be monitored. For example, it can cause major 2 side effects. One is hepatic fibrosis, and second is bone marrow suppression. So once you start any patient on methotrexate, you have to monitor them at least 2 to 3 monthly to look at the liver and look at the bone marrow. Leflunomide is another drug which is almost similar to methotrexate. The dose is 10 to 20 milligram per day. It can also cause hepatitis and bone marrow toxicity. The question is how effective these DMARDs and what are the strategies we should use them. The first question is how to monitor. That is the most important thing. Before anybody who treats rheumatoid arthritis, we have to look at these scores. This is a score which is called, for example, in diabetes, you look at HbA1c. In hypertension, you check the blood pressure. So what you check in rheumatoid arthritis is not gut feeling. There was a time when we used to treat patients based on gut feeling. How are you feeling? You are doing good. Okay, continue, or come down on drugs. But now there are standardized scores which are available for more than 2 decades, which the most commonly used one is DAS28, where basically it's a score based on tender joint count, swollen joint count, and ESR and global health. And based on that, the score is calculated. I don't want to go into details of this. All these calculators are available. So, but we have to target something called less than 2.6, or at least a low disease activity of less than 3.2. So that is extremely important. And there are other scores which are even easier. Just add tender joint count, swollen joint count, CRP, patient global, and physician global. If you add all this, you will get a score called Simplified Disease Activity Index. So based on that, you will get another score. And last but not the least, Clinical Disease Activity Index is without CRP. That is just add on tender joint count, swollen joint count, patient global health, and MD global health. Based on this, you will get a score. So whatever may be the score you calculate, at least you calculate one score and try to achieve the target. What is the target? Remission. If you achieve remission, definitely the patient will do well in long term. Otherwise, patient may not do well and the outcome may be bad. So whenever I'm going to talk on studies and stuff, always there's a benchmark. I have taken benchmark as anti-TNF, where usually in rheumatoid arthritis, response is calculated as ACR 20 response, ACR 50 response, or ACR 70 response and remission. So ACR 20, 50, 70 of 70 is just you reverse these three, 70, 50, and 30. 70, 50, and 30 will be if you achieve that kind of a response. ACR, if a drug can achieve ACR 20 of 70%, that is considered as to be good. So this is one of the trials which was published way back in 2007. What they did was very simple study. What they did was intensive treatment of rheumatoid arthritis. Intensive means very simple, monthly visit, rapid hike of methotrexate to 30 milligram in 4 months. And the conventional group, very slow. At that time, people used to come once in 3 months and slowly hike up the disease modifying drugs. What they could show was that, look at the remission rates. Remission rates were much higher in the intensive treatment group. Look at the blue bars, 35 to 40% and 50% at the end of 2 years. And mind you, this was a trial with a methotrexate monotherapy. So with methotrexate monotherapy, you can achieve remission up to 50. Remission means complete control of disease activity in 50% of patients if you give methotrexate properly. This was another trial which was called FINRACO. So the lesson learned here was even methotrexate monotherapy is very effective in around 40 to 50% of patients. Then next trial was a FINRACO trial, which is done in Finland, where they compared single DMARD versus combination DMARD and a pretty early disease. So most of the patient had very early disease. They presented very early within 2 years, and they gave half of them were given single DMARD like methotrexate, and half of them were given a combination of DMARD. As you can see here, this is a remission rate. This is combination. This is monotherapy. So with combination, you can achieve around 25 to 30% remission, while in monotherapy, you achieve a remission of around only 10%. Similarly, in second year also, it is almost similar. The combination therapy of 40% versus monotherapy around 15 to 20%. So the lesson learned was very simple with FINRACO. The combination therapy is superior to monotherapy. So if you give methotrexate and chloroquine combination, that is superior to methotrexate alone. And adverse event, that's why all of us are worried. If you give combination therapy, there may be more adverse events. The answer is no. The combination therapy and monotherapy, both of them are adverse events are comparable. And then came this landmark paper, which was published a decade back, where combination therapy group and single DMARD group were followed up for 11 years. 11 years. After the first 2 years, physician was free to give whatever treatment they want to give. If somebody in the single DMARD group, if somebody wants to give biologicals, they were free to give. You can see here in the single DMARD group also, a lot of patients were given biologic, rituximab, and other drugs were given even in the single DMARD group. So what the finding was that whatever superiority combination DMARDs had during the first year was carried over years. So what does this tell us? If you control the disease activity during the first year, the advantage what you have gained during that 1 year is continued over time and last for 11 years or ever. And whatever treatment you give from 2 years to 11 years doesn't matter. What matters is the initial treatment what you give. So initial control is most important. Initial diagnosis is what is most important. And one of this study you can see here, the remission was achieved in more than 50 to 60% of patients. That was a study which showed with combination DMARD, rheumatoid arthritis is very much treatable in majority of patients. And look at the function. 50% of the patients had a totally normal function and 24% had near normal function. So 75% of the patients were having a almost normal function at the end of 11 years, indicating that with conventional DMARDs, we can achieve a very good control in majority of patients. So similar time, there's another study which was published in Lancet, which is called TICORA study. TICORA study was very simple, where what they did was intensive treatment versus routine management. Intensive treatment was basically they tried to achieve a target of DAS less than 1.8 or 2. So, and vis-a-vis in another group, there was no target set. A rheumatologist was adjusting drugs based on his experience and his whims and fancies. You can see here, intensive group versus routine group, ACR 20 was response of 91%, ACR 50 of 84%, and ACR 70 of 71%. So very high ACR responses vis-a-vis the routine group, much higher. And I told you anti-TNF response rate is ACR 20 of 70. So if you see here, 91% of is much better than even the biologics. So this showed us that in the TICORA study showed us that this is not the drug which is important. It's not the combination which is important. It is the strategy of achieving the target is what is most important. So what is the treat to target and tight control? Treat to target means set the target as remission. What is remission? DAS 28 less than 2.6. How can you do that? You have to aggressively treat the patient and control the disease very well by doing frequent follow-ups. So these two concepts are extremely important: treat to target and tight control. So our lady came to us. She, as I told you, she had a very high disease activity. She is a well affluent patient. She started her methotrexate, chloroquine, and low-dose steroid, give intra-articular to the knees. Despite that, at 3 months, her DAS 28, you can see here, was 6.4. So she was a combo DMARD failure. So what do you do? Somebody has failed on combo DMARD. What do you do next? Then there are biologics like anti-TNF, IL-6 blocker like tocilizumab, or abatacept, which is a co-stimulatory blockade, or there is rituximab. So if somebody fails on DMARD, then we think of biologics. There is data with everything. I don't want to go into details of this, be it rituximab, be it anti-TNF, or be it tocilizumab. There is enough and more data to show that these drugs are extremely efficacious in patients who have failed on disease-modifying anti-rheumatoid drugs. And the ACR 20 response is something around 50% in all of them. So because she failed on combo DMARDs, she was started on etanercept, 25 milligram twice a week in 2015. But at the end of 3 months, she did not respond. Her DAS 28 just came down from 6.4 to 5.8. As I told you, our target is something around less than 3 or something around less than 2.8 to be ideal. So once somebody fails on one biological, what we should do is we should switch biological to another one, to rituximab or something else. This is a study which was called reflex study, where anti-TNF failures were randomized to rituximab versus placebo. As you can very clearly see, rituximab was much more efficacious. So then she went to CMC Vellore, rightly so, because she has failed on multiple things. She went there, she took a second opinion, and because she was anti-TNF failure, she was initiated rightly on rituximab, but she did not respond at all, and knee X-ray worsened, and TKR was done in 2016. So in November 2016, again she came to me. Despite TKR, she was wheelchair bound, and her ESR was 100. So she has failed on combo DMARDs, she has failed on anti-TNF, and she has failed on rituximab. Then what do you do? So basically, that is the time when 2015-16 was the time when JAK-STAT pathway inhibitors were available in the country. JAK-STAT pathways are small molecule inhibitors; they are oral tablets. As these are the four most important molecules which are available. Tofacitinib and baricitinib are the two things which are available in our country. If you look at tofacitinib, there's no doubt about the efficacy of this drug. These are very, very effective drugs. Be it across spectrum, these are major trials. I have summarized all this in one slide. Oral start, oral scan, just meaning one thing: be it methotrexate naive, methotrexate resistant, disease modified DMARD failure, or TNF inadequate responders. In all this population, very clear superiority of tofacitinib over placebo. You can see here placebo versus tofacitinib, and here if you can see here, the efficacy of tofacitinib is slightly better than adalimumab or almost equal to adalimumab, indicating that these drugs are extremely efficacious when you use in selected population. In across spectrum, be it methotrexate naive to biological failure. So across spectrum, tofacitinib is extremely efficacious. Same is with baricitinib, almost similar drug. I don't want to go into details of this, but almost all the population, be it methotrexate naive, be it refractory DMARD, they are DMARD naive or refractory to biological DMARD, baricitinib is also equally efficacious. And look at the comparison of baricitinib versus adalimumab. It is superior. So there is no doubt in the efficacy of these small molecules. But now why I'm concentrating on next 3 or 4 slides is basically to make you aware that they are very not extremely safe drugs as your pharma people or representatives may tell you. Because these are tablets, we think that maybe they are similar to disease modifying anti-rheumatoid drugs. This is from the global data of tofacitinib. What they excluded all the patients who had latent TB, meaning before starting tofacitinib, every patient was done tested for MAN2 and quantiferon TB. If they were positive, they were excluded. But as you can see here, TB rates were 1.21 per 100 patient years in India versus 0.1 in the global. So it is almost 8 times. So there is a definite risk of tuberculosis, and tuberculosis risk is 7 to 8 times of the rest of the world. So if you treat 100 patients per year, one or two are likely to get tuberculosis, and another 2 to 3 are likely to get serious infections, be it pneumonia, be it severe urinary tract infection, one of this. So 2 to 3 are likely to get severe infection. And you can see this usually in anti-TNF and biological, the risk is maximum during the first year, then it comes down. But with tofacitinib and baricitinib, the risk stays throughout. Around 2 to 3% keeps getting this kind of serious infections. And look at this, all serious infection risk is almost similar to all other biologicals, and it is higher than most of the conventional synthetic DMRs. So the message is, even though they are oral tablets, their side effect profile is almost similar to the biologicals. But another unique side effect this molecule has is that of herpes zoster, 3 to 4% per year. And we keep seeing, and herpes zoster is usually multidermatomal, affecting the multiple dermatomes simultaneously. And MACE is atherosclerotic cardiovascular major adverse cardiac events. If you look here, you can see around 0.2 to 0.4% of the patients who are treated with tofacitinib develop cardiac events every year. These are from psoriatic arthritis, B is rheumatoid arthritis. So the risk is around 0.3 to 0.4%. So if you look at the adverse events, if you treat 100 people per year, 10 will develop some kind of adverse event. 4 to 5 will develop herpes zoster, 1 to 2 will develop tuberculosis, another 3 to 4 will develop serious infection, and MACE and cardiovascular venous thrombosis like MI and DVT happens in around 0.5 to 1. So there comes this very relevant study which was published in New England Journal this year. What they did was they compared a huge number of people. Half of them were given anti-TNF and half of them were given tofacitinib. If you can see here, this increased risk is compared to the anti-TNF. For example, if somebody is on 5 years on anti-TNF versus 5 years on tofacitinib, one person will develop a MACE or MI or a stroke, while 1 out of 50, that is 0.5%, will develop a cancer. And this risk, mind you, is on top of anti-TNF risk. So TNF versus tofacitinib, there is a 1 in 55 will develop a cancer. So this is not a very extremely safe drug. There is early data emerging suggesting that increased risk of coronary artery heart disease and increased risk of cancer. Does it say that this is a very bad drug? I won't say that. You always, what I'm trying to tell you is, I keep seeing a lot of prescriptions across country of using tofacitinib upfront, being rheumatoid arthritis, being psoriatic arthritis, just use tofacitinib, like it is effective across spectrum in any arthritis. Even some people are giving it for osteoarthritis also. So please don't do that. This is a very potent drug, very useful drug in selected population, but has to be used very carefully under close monitoring. So this lady came back to me in 2016. I started on tofacitinib. Within 1 month, she became completely normal. Her DAS28 became 3.2. She started walking. Then what I did was, all this data was emerging over the last 2 to 3 years. I tapered tofacitinib and restarted disease-modifying anti-rheumatoid drugs, and stays on almost off tofacitinib now, but still under remission. So the message is the tofacitinib or baricitinib or anti-TNF, all these drugs has to be used in a selected population under carefully monitored. So rheumatoid arthritis has turned from M to T. M means masterly inactivity, mind-numbing pain, and misery. That was the rheumatoid arthritis in way back in 1980s, 1990s, and early 2000s also. We couldn't do anything. The patient comes with misery, and we see that, and we are not able to help the patient. From that, we have moved on to time to treat. As early as possible, you treat the patient. Treat to target. Control the disease to DAS 28 less than 2.8, and targeted therapy in the form of be it biological, be it targeted synthetic DMRs, these therapies are extremely efficacious, and we are able to achieve remission in most of the patients. Thank you for patient listening, and thank you for the kind invite to the Kerala Ortho Club. Thank you.
Thank you, Dr. Patna, sir. I think that finishes the medical aspects. Shall we go on to the discussions, Vishal?
Yes. So do you want to discuss on the long-term complications of rheumatoid?
Yeah, naturally. That's right. Sorry. My friend Vishad, he's a consultant rheumatologist based in Trivandrum. He's the director of IRIS, and he's one of the distinguished students in during his DM period from Sanjay Gandhi Institute in Uttar Pradesh. Over to Vishad for the complications.
Thank you, sir. So basically, we have been discussing about the approach to diagnosis, differential diagnosis, autoantibodies treatment. So what happens to a patient who has been diagnosed with RA despite all the treatment that we give? So we know that rheumatoid arthritis is a chronic debilitating disease, and this is associated with significant morbidity and mortality. And in fact, estimates say that the incident mortality rate in RA is approximately 4. That is, that goes on to say that a patient with RA is at a higher risk, 4 times at a higher risk of dying as compared to an ordinary, as compared to the general population. Besides, there is substantial morbidity related to RA, and this morbidity could be related to joint destruction. It could be related to the degree of inflammation, and it could be treatment-related morbidity. In addition, we have the economic and social morbidity related to the long-term treatment and the amount of money that is spent, the inability to participate actively in the social life. All this contributes to the morbidity in rheumatoid arthritis. So I'll just go into some of these one by one. So the morbidity related to the joint and soft tissue damage is, I think, to an orthopedic crowd, this is not something that I need to dwell too much into. We know that osteoarthritis, joint instability, tendon rupture, and nerve entrapment are fairly common in patients with rheumatoid arthritis. And our orthopedic colleagues have to actively intervene in many situations to help the patient in such situations. I would like to highlight 2 aspects here, which I think might be relevant. One is we have to recognize this entity, which is the cervical instability or the atlantoaxial disease, which is a fairly common cause, a fairly common symptom or common association in advanced rheumatoid arthritis. So what basically happens is that just like the wrist joints get affected, the cervical spine also gets affected in advanced and uncontrolled RA. So this is usually a manifestation of the cervical spine involvement in rheumatoid arthritis is usually a manifestation of advanced and uncontrolled disease activity. Patients often present with neck pain or neck crepitus. They complain of severe restriction of neck movements. They can have focal neurological deficits. Sometimes this can lead to vertigo or drop attacks due to vertebral artery involvement. Now, why is it important to recognize this entity? We have to realize that worsening of this compression by neck manipulation can be deleterious. And this is especially important when patients with atlantoaxial instability are being planned for surgery. So this is an aspect that needs to be considered whenever a rheumatoid patient is being considered for orthopedic surgery. Another entity that I would like to highlight is carpal tunnel syndrome. The reason why I highlight is very often patients with early rheumatoid present with carpal tunnel syndrome. It may be a manifestation of early disease due to synovitis, or it can occur fairly late into the disease due to joint damage. Carpal tunnel syndrome is the most common entrapment neuropathy seen in patients with rheumatoid arthritis. And the classical presentation is nocturnal paresthesia and sensory loss. Why am I highlighting this particular entity? Whenever a patient with carpal tunnel syndrome presents to us with in the background of RA, we have seen patients undergoing, especially those of them who have severe symptoms and those of them who have had a very severe carpal tunnel syndrome by nerve conduction study. Many of these patients undergo surgeries for carpal tunnel release. Now, the point that I would like to highlight is that Carpal tunnel syndrome can occur in rheumatoid arthritis in two aspects. One, it could be a manifestation of active synovitis, where the joint swelling can lead to compression of the median nerve, and this can lead to the symptoms of paresthesia and muscle weakness. Or it can be due to an advanced disease where there is significant damage to the wrist joint and there is compression of the median nerve. What we have to realize is that if the symptom is due to synovitis, very often a surgery can be deferred if we actively treat these patients with disease-modifying agents at the early on. However, if the patient doesn't respond in about, say, 6 to 3 months with disease-modifying agents, then these patients would be an ideal candidate for surgery. Other than the bony abnormalities due to joint involvement, another important long-term morbidity relates to the complications due to inflammation. So these morbidities may be localized in the form of ocular manifestations like dry eye, scleritis, and advanced scleritis can lead to scleromalacia perforans. We know that rheumatoid can affect the parotid and other salivary glands, leading to severe dry mouth. Rheumatoid nodules are another manifestations of active rheumatoid, long-term rheumatoid, and this can lead to ulceration and even compression and complications. In addition, the complications due to inflammation can be systemic. In fact, there are more dreaded complications. The classical rheumatoid complication, inflammatory complication, is the rheumatoid vasculitis. Amyloidosis, fortunately, is very rare nowadays, although previously it's a multi-system condition occurring secondary to chronic active rheumatoid affecting almost all organs of the body. But thankfully, due to the better control of disease activity, these are two complications we do not see so often. What I would like to highlight on are these 3 or 4 other systemic manifestations in rheumatoid. This is interstitial lung disease, osteoporosis, cardiovascular disease, and to some extent neoplasms. So these are 3 or 4 other conditions that we face very commonly in patients with rheumatoid, and timely diagnosis and prompt intervention is very important in managing, in averting complications related to these conditions. So just to briefly go back, this is the ocular manifestation. This is scleritis. Chronic scleritis can lead to long-term blindness and perforation of the sclera and leading to scleromalacia perforans. So just to remember, any patient with rheumatoid who presents with a red eye, just be careful. Make sure that they are seen by an ophthalmologist and a proper diagnosis is made, whether that is episcleritis or scleritis. Long-term scleritis can lead to this complication and scleromalacia perforans, so this has to be averted promptly. Interstitial lung disease is yet another manifestation, which I said, it is an important manifestation.
Slides are projected. Slides are, I can't see. I don't know, others can see.
Is it?
Yeah, do you have slides? We thought we don't have
thought,
slides.
we thought
I have been
shared.
we thought
That
you are
now I
talking
realize.
extemp.
We thought you are on talking
Yeah.
from here.
Sorry. Shall I start from the present slide?
Yeah, sure.
Yeah, that is enough. Yeah. It was just a good flow of knowledge, Vishal.
Okay, sir. So you thought I was doing an extempore?
Yeah, we all
Yeah,
thought it.
definitely.
Okay.
But sometimes without slide also is good.
Yeah, it's very true, sir.
And is my slides visible now?
Yeah. Okay.
Yeah, I think I'll just start from this slide.
Yeah.
So the complications, I think initially I had mentioned about the complications related to direct joint inflammation and joint damage. Second set of complications are due to systemic inflammation, inflammatory burden in rheumatoid arthritis. So these complications can be localized or systemic. Localized complications, we are quite familiar with the ocular manifestations and the parotid manifestation, that's a secondary Sjogren syndrome leading to dry eyes and dry mouth. Alternatively, especially in case of severe uncontrolled RA, this can lead to inflammation of the sclera, and if not properly and promptly treated, this can lead to perforation of the sclera and permanent blindness. Rheumatoid nodules are yet another manifestation we are all familiar with. Sometimes these rheumatoid nodules can get ulcerated and infected, and or can cause compressive symptoms and may need intervention. The systemic complications due to rheumatoid includes the classical systemic manifestation is rheumatoid vasculitis, which is where there is an excessive inflammatory burden due to rheumatoid, and the rheumatoid starts to, we can say in a very simple manner, we can say that rheumatoid starts to spill out from the joints and start to affect the small blood vessels and involve the organs supplied by these small blood vessels. Amyloidosis is a complication of long-term rheumatoid. Thankfully, this is a manifestation of uncontrolled rheumatoid, a very dreaded complication. Thankfully, because of better drugs and better control of disease activity, this is a pretty rare complication nowadays. The last 4 complications are fairly common, and these are the interstitial lung disease, osteoporosis, and cardiovascular disease. I would like to spend a little more time on discussing about these 3 complications because they are it is important that we recognize them early and promptly act. So interstitial lung disease basically refers to a condition characterized by reduced respiratory capacity due to inflammation and fibrosis of the lung parenchyma. And I think it would be surprising to know that the prevalence of interstitial lung disease is up to 60% if you do image every single patient with rheumatoid. However, only about 17% of these patients with interstitial lung disease have overt manifestations and become symptomatic. Now, who are those patients who are likely to develop interstitial lung disease? This is more common in patients with anti-CCP positive rheumatoid arthritis. And although we associate interstitial lung disease with a longer disease activity, longer duration of disease, we should realize that it can be seen about 40% of 40% of interstitial lung disease can be seen very early, within less than 2 to 3 years of diagnosis. And even before diagnosis of rheumatoid arthritis, sometimes rheumatoid can present with interstitial lung disease in about 10 to 17%, in whom testing for antibodies may be positive. Now, why is it important to diagnose interstitial lung disease for us as physicians and orthopedicians who are managing rheumatoid? What we should realize is that interstitial lung disease can be progressive in about 30 to 50% of individuals. And once you diagnose an interstitial lung disease and you do not focus your treatment on interstitial lung disease, the median survival is reduced by about 2.6 to 8 years. And the 5-year mortality of patients with interstitial lung disease is about 40%. So it is, I think that the reason why time to recognition of interstitial lung disease cannot be overemphasized than by projecting these statistics. So as I mentioned, people who are anti-CCP positive, people who have a longer disease duration, males, especially those who smoke, people who have uncontrolled disease activity, and obese individuals. These are the ones in whom we have to keep a higher index of suspicion for diagnosis of interstitial lung disease. So when to suspect interstitial lung disease? This is often detected during routine clinical examination. Patients may just complain of some odd cough here and there. Some of them may complain of dyspnea on exertion. And if you look closely at the chest, often you may be able to capture the bibasilar crepitations. We have to remember that at least in a subset of these patients with interstitial lung disease, it can be very rapidly progressive. In fact, we have had patients who developed interstitial lung disease in rheumatoid and progressed very rapidly in a matter of few days and became unsalvageable. So it is important that we look at these clinical signs as well as these look at this patient, test the patient, question the patient regarding these symptoms whenever we are dealing with a patient with rheumatoid at the first diagnosis as well as during follow-up. And once you have diagnosed, once you suspect a rheumatoid-related interstitial lung disease, you can confirm it by doing a high resolution CT scan or a pulmonary function test. And it is important that if you have diagnosed an interstitial lung disease, you have to avoid drugs like methotrexate, leflunomide, and anti-TNF, because some of them can complicate the lung disease in the background of the interstitial lung disease in the background of rheumatoid. In those patients in whom we have diagnosed an interstitial lung disease in the background of rheumatoid, rituximab and mycophenolate mofetil are some of the preferred treatment options. Another important comorbidity that I would like to highlight is cardiovascular disease. It would be surprising that we are talking about cardiovascular disease in rheumatoid, but it is, in fact, it is not really so. What studies, briefly, let me just introduce what cardiovascular disease is. It just refers to diseases which relates to the blood vessels such as stroke, myocardial infarction, and those which relate to the heart, such as congestive cardiac failure. How many of us know that the risk for cardiovascular disease in rheumatoid arthritis, especially in an uncontrolled rheumatoid arthritis, is equivalent to that of seen in diabetes? It is in fact true. There is about 50% increase in risk of stroke in patients with uncontrolled rheumatoid arthritis. It's much similar to diabetes. These figures are much similar to what we have in diabetes. About 100% increases for myocardial infarction patients with uncontrolled rheumatoid arthritis. And there is 1.2 to 1.5 times increases of mortality due to cardiovascular disease in RA. In fact, patients with rheumatoid arthritis, especially because the disease per se has become eminently treatable, cardiovascular disease has emerged as an important cause of morbidity and mortality. And what people have found is that in those patients with rheumatoid with cardiovascular disease, there is an decrease in life expectancy by about 6 to 7 years due to cardiovascular manifestations. So why does cardiovascular disease occur in rheumatoid? There are those traditional risk factors such as tobacco, smoking, exercise, blood pressure, lipid profile. These are all things that we need to screen for in patients with rheumatoid and diabetes. So along with these traditional risk factors, we have the inflammatory burden. What people have shown is that inflammation per se can lead to atherosclerosis and can lead to cardiovascular disease. In addition are the role of medications such as disease-modifying agents, some of the disease-modifying agents, glucocorticoids and NSAIDs, which also contribute to cardiovascular disease. So it is sufficient to know that people with rheumatoid are at an increased risk of cardiovascular disease, and it is important that we do a proper screening and management of traditional cardiovascular risk factors such as diabetes, hypertension, lifestyle modification, and a prompt control of inflammation is also required to avert long-term cardiovascular morbidity related to rheumatoid. And as Dr. Shenoy said, we have to be beware of some of the medicines, particularly beware of some of these medicines that we use, which have a heightened cardiovascular risk. For example, use of anti-TNF in a patients with cardiac failure can be fraught with fire because it can lead to worsening of cardiac failure. Tofacitinib and bedacitinib, the newer magic bullets, so-called magic bullets, can in susceptible patients can lead to a higher risk of thromboembolism as well. The third important morbidity that I would like to highlight, especially in an orthopedic crowd, is osteoporosis. I think both of us deal with osteoporosis. We have to realize that rheumatoid is a condition which affects bone, and there is a lot of inflammation that goes on. And about 30 to osteoporosis inflammation can lead to bone loss and osteoporosis. About 30 to 50% of RA patients, in fact, have osteoporosis, and there is a nearly twofold increased risk of fracture in those patients who suffer from rheumatoid due to osteoporosis. So the osteoporosis in rheumatoid arthritis may be multifactorial. It may be due to the effect of pro-inflammatory cytokines, which lead to bone mass, loss of bone. It can be due to poor biomechanics, because these patients with rheumatoid are often frail and unable to do proper weight bearing, which we know is very important for building up the bone. In addition, the drugs such as corticosteroids and even methotrexate can lead to osteoporosis and bone loss and subsequent fractures. Osteoporosis is generally related to the duration and severity of the disease. However, what studies have shown is that, especially in the metatarsal heads, osteoporosis can occur even before the diagnosis of RA in patients who are anti-CCP positive. So osteoporosis and rheumatoid are very closely interlinked diseases. In the context of rheumatoid, there is potential for local as well as systemic osteoporosis. Patients can have, I'm sure that most of us have noticed some of the patients who with the rheumatoid who go for a bone mineral density study, you find that there is a profound bone loss, especially in the wrist joint due to inflammation. And although the other joints may be, although the spine and hip BMD may be preserved, even these patients are at increased risk for wrist fracture as compared to controls. So what about the association of drugs and osteoporosis? Glucocorticoids, we know that they are closely linked with osteoporosis, especially long duration of usage are associated with significant osteoporosis. But paradoxically, what has been shown is that short duration of glucocorticoids for, let's say, less than 3 months, because they control inflammation very promptly, may even prevent bone loss and can be counteract the osteoporosis. So this is one aspect. Whenever we criticize steroids, we say that it can cause osteoporosis and bone loss, but do remember that it can be helpful in certain settings. So when required, if we are finding difficult to control inflammation by other means, I do feel that we can use small doses of steroids, because we need not fear, we need not be very dogmatic about osteoporosis and other complications. Most DMR, use of most DMRs and biologics, generally they are associated with reduced risk of osteoporosis because of better control of disease. But standalone use of drugs like methotrexate and corticosteroids in a patient who has a properly controlled disease, they can actually worsen osteoporosis. So it is important that we use calcium and vitamin supplement for all patients with osteoporosis, and use of anti-osteoporotic medications may be applied in appropriate settings. So whom should we screen for osteoporosis? So this is the NOF guidelines, the National Osteoporotic Foundation guidelines. So according to this guideline, what they say is that any adult with a condition such as rheumatoid arthritis or taking any medication that causes osteoporosis or cause low bone mass may be screened for osteoporosis. This may be a little overkill. So what I would suggest is that we should screen at least those patients who have a long-term debilitating disease, those who are on corticosteroids, those elderly ladies. At least these patients we should be able to screen and properly pick up osteoporosis and act before they develop a severe morbid hip or spine fracture. I think although I highlighted the three comorbidities which have become increasingly prominent, because these three comorbidities such as interstitial lung disease, osteoporosis, and cardiovascular disease, these are actually the byproducts of longevity which is associated with RA. Because RA is being treated very well, the conventional complications such as scleritis, scleromalacia, amyloidosis have gone down, and even rheumatoid vasculitis, the life-threatening manifestation rheumatoid has also gone down. But I think I'll be failing my duty if I do not mention this, because this is one situation where we need to be very prompt. When any patient, any of us who are dealing with rheumatoid arthritis, we should be aware of this complication and should be capable of diagnosing it early enough so that we can salvage the patient. So rheumatoid vasculitis is a very condition which is a complication of rheumatoid, which has a high mortality and morbidity. It is usually seen in advanced RA, but it can be seen in improperly controlled disease activity and in patients with burned out or deforming RA. When should we suspect rheumatoid vasculitis? Any patient with RA who comes to us with significant weight loss, significant fever, or presence of even skin gangrene, non-healing ulcer. Any patient with rheumatoid who presents with a new onset uncontrolled disease, who presents with a new onset sensory numbness or paresthesia or weakness, or any discoloration of the skin, even palpable purpura like seen in this. These are all things we may tend to miss unless we are aware and we have a heightened sensitivity to pick them up. So any patient any patient with rheumatoid, especially with uncontrolled activity, in whom we have identified, we can identify any of these manifestations, do promptly intervene and treat with, I think the rheumatologist or the physician would be the best person to manage here. They can give added immunosuppressions and such as pulse methylprednisolone, cyclophosphamide, or rituximab. These patients should be properly identified and promptly referred. Now, as the treatment of rheumatoid arthritis has progressed, the complications which are related to rheumatoid arthritis, treatment-related to rheumatoid arthritis have also increased in number. Dr. Shana had mentioned a few of them. So hepatotoxicity, myelotoxicity, chronic and acute infection, higher risk of neoplasms are all emerging complications related to or increasingly recognized as complications related to treatment of rheumatoid with conventional disease modifying agents. And those patients who are treated with biologics, infection, particularly tuberculosis, especially silent infection. I would say a word of caution here, because I think most of us are using biologics, have started to use biologics in rheumatoid. Only a couple of weeks back, I had a patient of ankylosing spondylitis on treatment with treatment with adalimumab. Patient had been doing very well for the last 3-4 years without any symptoms. He was quantiferon TB Gold negative. He had a normal CT scan at onset. So because this patient was not affording adalimumab anymore, I tried to change over to tofacitinib. And just before changing over, I thought we'll have a rescreening for tuberculosis in this patient. And to my surprise, what I found was that large cavitating lesions in the lung, which was completely asymptomatic. And when sputum was tested, it was positive for AFP. So do keep this in mind. And I think it is a good practice for all of us who are dealing with rheumatoid and even tofacitinib to do a repeat CT X-ray, at least an X-ray every year when the patient is on treatment for with the biologics or oral or tofacitinib. Another complication with the long-term biologic is demyelinating disease and lupus. Only last day I had a patient, long-term rheumatoid, on treatment, doing steadily well, complained of sicca symptoms about a couple of weeks back. Patient was being treated with etanercept, complained of sicca symptoms a couple of weeks back. Patient presented with acute inducible pneumonitis about 3-4 days back. So basically, when we evaluated, what we found was that the ANA was positive and all the other lupus-related antibodies were positive. So in those patients, especially in those patients, we are giving long-term biologic. Be sensitive to this fact that when these patients complain of any other systemic manifestation, do think about a conversion of this disease to a connective tissue disease such as lupus or Sjogren's. In addition, we had mentioned about the worsening of cardiac failure. Biologics have been proposed to be associated with some malignancy. Chronic biologic use have been proposed to be associated with malignancy. Most importantly, non-melanomatous skin cancer. And what about the hardcore long-term outcome, that is mortality? So this was one interesting study which was done in Italy. What they found was that patients with rheumatoid are about 1.42 times increased risk of dying. The average, any patient who is being diagnosed with rheumatoid has an average, when you follow up for 15 years, they have an average 1-year reduction in survival. And as we mentioned, because the disease is better controlled, the cause of death has shifted to cardiovascular disease than due to directly related to rheumatoid. The second major cause of death is neoplasms, and third cause is respiratory diseases. Now, how effective have been our treatment? I think this graph is very important and this is very impressive. So this was one study which looked into the mortality in patients with RA before 1970, from 1970 to 1983, and from 1983 onwards. And there has been a substantial reduction in mortality, the incident mortality rate from 4.7 before 1970 to around 2 from 1983, thanks to the advent of newer treatment modalities. So to conclude, I think I've been able to impress upon you this fact that rheumatoid arthritis is associated with significant mortality and morbidity. And these are related to the 3 Ds, that is disease activity, damage, and drugs. And it is important that it is heartening to know that it is possible to better control the disease activity in rheumatoid. But along with this better control and disease activity, we are faced with newer long-term complications, newer challenges in managing of long-term rheumatoid. Morbidity and mortality due to these complications are eminently treatable, and it is important to closely monitor and timely recognize so that we can promptly intervene. Thank you.
Thank you, Dr. Vishad. We have actually overshoot our estimated time, but it was very informative. So I think we can take a few questions if they are available. Any questions on the medical aspects? Evelina? Hello? Anil?
Sir, no, we are not seeing any questions on chat
So
box.
shall we go to the surgical aspects?
Yes.
Okay, so shall I invite Dr. Vinod Padmanabhan? Dr. Vinod?
Hello. Yeah, can you listen to me?
Yeah. Okay.
Yeah, Vishad, can you stop screen sharing your screen?
Vishad, can you exit your screen?
Stop sharing so that.
Dr. Vinod Padmanabhan is senior consultant at Sudhindra Medical Mission, Cochin. He is the HOD of orthopedics there. He did his MBBS from Gwalior, D-Ortho from KMC Manipal, and DNB from Bombay Hospital, Mumbai. He also had his fellowships in arthroplasty, DePuy fellowship, and the joint reconstruction fellowship, and adult reconstruction fellowship from Stuttgart and Stanmore. Over to Vinod for his talk.
Yeah. Can you listen to?
Yeah, fine.
Right. So first of all, thank the organizers for inviting me here. And I'll be talking about it's a cusp between the medical and the surgical part. The current updates on indications and perioperative management paradigm of arthroplasty and rheumatoid arthritis. Right. So success of any arthroplasty depends on 4 S's: the setup of the hospital, substance, the surgeon and the staff, and the selection of the patients. We all know, I won't go into details of it. Nowadays, most of the theaters are having laminar flow with the role of anesthetists, scrub nurse, staff, the OT personnel, and the physiotherapists. And the substance use. Most of the implants available are now good quality implants. And even we have some very good we have some very good Indian implants also available, which are locally manufactured. Surgeons should be well trained in arthroplasty, updating knowledge, having an interest in recent advances and academics in the research. And selection, last but not the least, the selection of the patient, I feel, is the most important S here. And here, when you're dealing with the indications of arthroplasty in RA, definitely failed non-operative treatment, grade 4 degenerative changes, and the ones which are affecting ADL. As Dr. Shanai told, many of them are getting better, and with the newer advent of especially the biologics, the need for surgery is becoming lesser and lesser. But when they are so debilitated, then only the surgery is indicated. But whenever in doubt, especially aspirate to rule out infection or do an arthroscopic sinual biopsy. Don't hesitate to do an arthroscopic sinual biopsy before taking up the patient for arthroplasty in the theater, because sometimes you can burn your fingers if there is a overt infection there. Now, preoperatively, counseling is very, very important. The patient expectations, you should know. In informed consent, medical checkup, that's a routine things what are done before any arthroplasty. And here the role of rheumatologist is also important, because the rheumatologist has to give the fitness as far as the disease activity is concerned, and that is a very important thing here. Now, coming to the medical aspects of rheumatoid arthritis, it requires some special care in the perioperative settings, and that is the assessment of the cardiovascular risk, management of the immunomodulatory therapies, perioperative corticosteroids, airway management in the light of risk of C-spine involvement, and heightened infection risk due to the disease and its treatment itself. So coming one by one is the cardiovascular risk. There is definitely, as the previous speaker told, the higher risk of myocardial infarction is there, increased risk of death is there, and there are a lot of cases in which unrecognized disease is there. And American College of Cardiology and American Heart Association recommend that active cardiac conditions must be rolled out. So increased risk of unstable coronary syndromes and decompensated heart failures are there, and which should be rolled out. If the patient is able to complete about 4 meds, the perioperative risk is low. And often they are unable to be readily, because of their immobility, they can't undergo those their functional capacity cannot be assessed properly. So the recent revised cardiac index RCRI, as incorporated in the American Heart Association, it includes the ischemic heart disease, compensator or prior heart failure, the use of insulin, renal insufficiency of creatinine more than 2, and cerebrovascular diseases. They are all important comorbidities where you should be very, very careful before taking up the patient. RA and ILD, again, is a repeat of the previous things, that it is very, very common. We have seen a lot of cases in our hospital, especially Dr. Shanai's cases, where patient had ILD. In fact, we have operated a few cases of ILD also. And 2 pulmonary risk indices have been published. That is the prediction of post-operative pneumonia and the respiratory failure occurring after the surgery. So I think this is a very important thing, that if the FVC is less than 1 liter, definitely there's very, very high risk of pulmonary complications post-operatively. Pulmonary artery hypertension is also secondary to ILD, is a potent risk factor. But again, newer medications are effective in reducing the pulmonary artery hypertension. Cervical spine disease, though most of the surgeries, hip and knee, are done under spinal or epidural anesthesia, but you should be prepared to give a general anesthesia also. And there comes the role of C-spine. And most of them have cervical instability in RA can be as high as 61%, few studies have shown. And especially the anterior atlantoaxial subluxation can range from 18 to 49%. here, though it's a big slide, the evaluation of the posterior atlanto-odontoid interval, that is the key thing here, can help in assessing the risk of paralysis in patients with RA who are undergoing a GA. So the AO interval, atlanto-odontoid interval of less than or equal to 14 mm is associated with increased risk of paralysis. So that's an important indicator to be measured before taking up the patient for GA. Now, coming to management of medications, three categories of medicines, mainly biologics, DMARDs, and the corticosteroids. And patients with RA, they have higher rates of infection at baseline compared to others. This I'm talking from the surgical point of view. So the optimizing the use of immunosuppressants in the perioperative period is very important. So the risk of infection, delayed wound healing must be balanced with the risk of flare-up, which if occurs, this is a very, very crucial thing, because sometimes post-operatively the disease might have flared up, but then you are confused whether it is due to your surgery or due to the disease activity. And it requires an escalation of immunosuppressants such as corticosteroid. So it is very important preoperatively. I think this is the take-home slide here, that RA disease activity must be well controlled before taking up the patient with appropriate immunomodulatory drugs rather than depending on the corticosteroids. And corticosteroids should be reduced to the minimum to ensure better post-op recovery and reduced flares. So these are a few from the 2017 ACR and American Academy of Hip and Knee Surgeons guidelines. And the guidelines for the medication, non-biologic DMARDs may be continued throughout the perioperative period during elective arthroplasty. The biologic medication should be withheld as close to one dosing cycle as scheduling permits prior to elective THA and TKR, and restarted after evidence of wound healing, which is usually 2 weeks from surgery. So as you see in this slide, methotrexate, sulfasalazine, all these things can be continued. In fact, though we still stop it about 1 week prior, especially only the methotrexate. And rest all biologics, definitely you have to stop it at least one dosing cycle before that. And this is the biologic agent, stop these medications. These are the guidelines from the ACR and the American Academy of Hip and Knee Surgeons. Now, management of medication, especially the corticosteroids, here again, the ACR guidelines are there, where hemodynamic instability and hypotension, infection risk were two specific areas of concern with regard to the glucocorticoid dosing. Though initially they used to give something called supra-physiologic glucocorticoid doses or the stress dosing, but it is not found to be very effective. And it is seen, I'll come in the next slide about it, and specifically refers to adults with rheumatoid arthritis who are receiving glucocorticoids less than or equal to 16 milligram per day or prednisolone or equivalent. Now here, there was no significant hemodynamic difference between those patients given their current daily glucocorticoid dose as well as the compared to those receiving stress dose steroids. And observational studies have demonstrated that an increase in infection risk will happen if the long-term steroid use is more than 15 milligram per day when the patient is being taken up for surgery. So definitely try to reduce the steroid intake at the time of surgery. And optimization of THA TKR should include careful tapering of glucocorticoid prior to surgery. Now, that was the medical part. Now we're coming to the orthopedic part. Preoperatively, all these patients have a lot of complex deformities, and it's not like a OA. It's a definitely a different ball game in rheumatoid arthritis, where it's not only the knees, or it will be complex deformities. Sometimes one hip or two knees, or it will be like that. So you have to assess them properly and then decide, which all joints are involved and what is the sequence in which you're going to do the arthroplasty. Secondary infections like COX should be ruled out, as I told earlier, either by aspiration or the arthroscopic sinus biopsy. Definitely UTI, respiratory tract infection, dental is done routinely for all arthroplasties. So you'll come across all kind of spectrum of diseases, and I was fortunate with working with Dr. Shania to get almost all spectrum of rheumatoid arthritis. These were one of these difficult ones. And so when you have very severe severe FFDs, then sometimes preoperative tractions are also needed to stretch out the posterior soft tissues. And when hamstring lengthening also has to be done for 1 or 2 cases and releases, and additional distal femoral cut is the usual thing what is done for dealing with the FFD. So this was one girl and who had severe FFD, and on table we couldn't stretch out much, and then we did a fractional hamstring lengthening as well as, and then additional distal cuts were taken, and 1 year follow-up of this girl, and she's doing well. Now she's about 7 years follow-up now. And intraoperatively, you'll come across a lot of very thin skin, not very healthy skin. Intra-articular, a lot of adhesions will be there. Tough tissues, which will be very difficult to dislocate, but at the same time, very soft bones. So patellar tendon avulsions can happen. So avoid using very forceful manipulation for dislocating the knee or doing using a posterior retractor. Very often for very stiff knees, you have to do a TT osteotomy or a snip, but depending on whatever. I am quite happy doing a TT osteotomy, but I know a lot of people do snip and they have very good results also. So this is one of the cases where the patella was completely adhered, and you can see that she had totally stiff knee, and so in trop, definitely we had to do a tibial tubercle osteotomy, and post-operatively we had to fix it, and this was the result, and 1 year follow. Though you should not give them very high hopes that you will get full flexion, but if they get even up to 90, that's good enough. Intraoperatively, extensive synovitis will be there, so it's better to do a complete thorough synovectomy and send the synovium from gram stain, and if possible, do a cell count on table to rule out infection. So many of them have this disease synovium. Bones will be very sclerotic and hard, and few areas will be very soft. So spiked jigs can be avoided. So I also learned it the hard way. We had a couple of tibial condyle fractures. This was a very stiff knee, which we had to do a tibial tubercle osteotomy, but then he had a tibial condyle fracture also, so which needed to be fixed here. And but he did well. After 6 months, we removed all the screws, and then he was doing well. Another case where a patient had a very, very soft bone while dislocating. The tissues were tight on this side, and actually it just stretched out here, and even it got the small crack. And then, but we could manage with 2 screws, and they heal quite well. That's the advantage here. And this was a case where I didn't have a stem backup on table, so we just managed, keeping our fingers crossed, but 1 year follow-up and she was doing well. So even PCL retention, it's difficult. We've gone through the literature, and PCL retention is difficult, but it can be done. And we have one of my fellows have written a paper on, and we have quite a number of cases where we have retained the PCL. Keep a watch on the PCL till the end, till the final implantation. If it avulses, then you can change to PS before implantation. But after implantation, if there is some avulsion or something, either you can fix the avulsion with a screw, or even a deep dished insert can be used. MCL avulsions, not very rare. In fact, we had 2 or 3 cases where the MCL avulsed. Another fellow has written about only the complications of PKR in rheumatoid arthritis. And but again, as I told, they unite well, quite well, and you don't have to actually keep them totally non-weight bearing. They can be mobilized, but you have to go a little protected weight bearing. And post-op 1 year follow-up, we had a good result. Few of these, I'm not going to these details because Harish will be anyway talking about this in detail. So very severe valgus, FFD. She underwent a hip at EHR first, and then the knee was bad, and almost 2 centimeters uncontained defect. So had to be managed with a stem and a big wedge here, and well aligned knee. 6 weeks post-op, and she was doing quite well. And so another patient, he had a very bad knee. Actually, it was one of the worst knees, and in fact, half of his condyle had gone off on the left side. So right side we could actually still manage with a regular TKR, but left side we had to put in a hinge here, and so this was on the right side, and he did quite well. In fact, he was quite happy. His muscles were quite okay, so he could stand and walk the day one itself, and 3 months post-op, and he was a happy man. Thank you.
Thank you, Dr. Vinod. We'll move on to Dr. John's talk. Dr. John T. John is HOD and Senior Consultant in Adult Reconstruction and Sports Injuries in Lourdes Hospital. He did his MBBS from Government Medical College, Kottayam, MS Ortho from one of the prestigious institutes in India, AFMC. He also has a lot of fellowships. It's a long list, MCH, MRC, SFRC, on it goes. So over to John for a topic on hip surgery, hip replacement.
Thank you, Ramakrishnan, for the wonderful introduction. Hope I am audible and my screen is visible. So my topic is patient selection, implant preference, and specific challenges in rheumatoid hip arthroplasty. So rheumatoid arthritis, we had a long lectures by medical people, and we know that it's a systemic infection, not only the joints, many other systems. What we have studied all will get involved in this disease scenario. So they can have peripheral and systemic polyarthritis. They will have joint deformity and destruction due to erosion of cartilage and bone. In general, patients with rheumatoid arthritis undergoing THR are younger than patients with osteoarthritis or other problems. Rheumatoid patients undergoing THR can encounter more complications than those with osteoarthritis. We'll come to one by one. So in total hip arthroplasty, rheumatoid poses specific challenges to the replacement surgeon. Rheumatoid arthritis strongly affects the properties of the bone. It affects not only the disease per se, the medicine also affect the bone metabolism. So you can have mechanical complications, especially in cementless implants, can have periprosthetic fractures, inefficient initial implant stability, and inefficient osseous integration leading to early implant failure. So problem anticipated generally, we'll divide it into hip dislocations, early revisions, shorter processes durability, infection, and venous thromboembolism phenomena. So if you look at the dislocation per se, it is one of the common and one of the dreaded complications in hip replacement. So if they are generally, we use smaller size people, so the size of the head will be usually 28, and they have more, like compared to the 32 size head which we commonly use. The 28 heads have 3 times more chance of dislocation. Then another common thing is protrusio of the acetabulum is more common in rheumatoid arthritis. The upward migration of the acetabular roof as such can also be seen because of the erosion and softening of the bone, leading to the weight-bearing part of the acetabulum to erode and the head to go up. Collapse of the femoral head and destruction of the acetabulum can also lead to dislocation. And as such, there will be severe osteoporosis, which has already been dealt with, and relatively worse condition of the soft tissue. The abductor power may not be good. Patient may not be walking. You must be having different types of deformities, like a fixed flexion deformity or an adduction deformity. So you might have to go in and do an adductor tenotomy earlier, or you might have to correct the fixed flexion deformity, then you have to go in. So one thing we commonly find is that because of the synovitis, they may be holding it really hard. So you have to, after giving the anesthesia, you have to again examine and determine what all deformity the patients have. So if you find there is an adduction deformity of more than 20 degrees straight away, it is better to go and do a tenotomy, adductor tenotomy preoperatively itself. All this correction of the deformities should be done before you implant so that you can correctly identify when you are doing trialing whether it will dislocate or not. And there are even studies which recommend the use of constrained acetabular component like a dual mobility implant or a constrained liners in rheumatoid arthritis with severe deformities. Periprosthetic infection, as Vinod was saying, they have, it's like in the knees, in the hips also, they have a high rate of infection compared to the normal population because it is generally an autoimmune disorder which affects the immune system. And nowadays there are a lot of biologicals like infliximab and Enbracet, which has been associated with high risk of periprosthetic infections. And there you have to have a good rapport with your rheumatology colleagues to know when to stop and when to decrease the doses of different medicines which is being used for the treatment of rheumatoid arthritis. Otherwise, there is always a high chance of infection in this patient group. Another, if you look at the, there is shorter processes and choice of implant. And if you come to it, the choice of implants is always a controversial. Like from the days of our post-graduation to now itself, whether it is to do a cemented processes or an uncemented processes is still a debate. But generally, since they are arthritic, I mean, they are osteoporotic, we generally prefer to do a cemented femorals and an uncemented cup. But general consensus that cemented process is thought to function inferiorly when compared to OA patients. So that is some studies also say like that. Uncemented processes, though questionable, is more promising. Even though some studies say that the uncemented, the integration of the process is less because of the affection of the bone metabolism in the disease per se. So uncemented stems porous coated has significantly higher, lower risk of revision or for aseptic loosening. And uncemented cups have higher rates of revision when compared to all polycemented cups. So a reverse hybrid is generally recommended earlier, but that is also being changed because most of the time you have to have where there is a protrusio or when there is a large erosion, you have to go in and try to think of putting a uncemented cup there. And because of severe osteoporosis and the chance of periprosthetic fractures, the intra-op fractures are there, it's always better to use a cemented stem. So periprosthetic, we see tight Vancouver fractures, proximal femur fractures, and because if you have unlimited time of power integration and chance of lose and the subsidence of the stems are high. Early and aseptic loosening, there's no evidence of increased incidence in rheumatoid, but generally the late aseptic loosening is high in case of uncemented stems, leading to periprosthetic fractures. So acetabular component outcome, if you look at it, preparation of the acetabular floor with thread is very important. You have to remove all the fibrous tissue in the inside the cup and really find the floor, and then only you have to go in and preen carefully. And if there is a cyst or there is a protrusion, you have to bone graft that area. And then it is always better to have a rim fit design rather than a central fitting cup. The peripheral fitting cups do well because because of the osteoporosis, if you go and hammer in a lot, you can have a fracture there. So early loosening and cup migration are one of the problems which is usually seen in rheumatoid arthritis. If you look at femoral component outcome, there is when you are using uncemented stems, there is in high chance of fractures are there, and subsidence are also seen. And early loosening is more commonly seen in cemented stems because of less integration of cement. So this is we'll go through some of the cases. This patient, 66-year-old female, left-sided, was operated previously, and you can see both sides. Cemented implant system was used, and there itself you can see there was a GT avulsion, which was tension band was done. The other side you can see now they are presented with large protrusion with proximal migration. So here you can see we have used the bone graft, the femoral head. And one thing we usually take, you can see from the femur also, we take some bone from here and put it in here. And generally, we try to use a cemented stem. And again, when there was a GT avulsion, we have to do a tension and bearing. So bone are really weak. So the chance of periprosthetic avulsion fractures are very high. And using an uncemented stem can also lead to fractures in the femoral stem side. This because these are all like as we are evolving in practice nowadays, we tend to do more of an uncemented cup and stems. So this was done quite a bit back. I think this was done around 14-15 years back, and this was the right side was done around 6-7 years back. So nowadays we are more towards changing to uncemented stems and cups, and we'll see what are the complications. This is a 68-year-old female male truck driver by profession, rheumatoid arthritis. He also had very bad erosion of the bone, some new bone formation here and there, some history of trauma also. Some kind of myositis also happening. So this was the CT. We went in and did a bilateral, again, similar thing, a hybrid system, a cemented stem and a uncemented cup. And we generally, if you look at it, the size is, in this case, we thought the abductors will be weak. So we have used a larger 36 head. But in the previous case, you can see it was a 32 head, which was used. This was a follow-up X-ray. This is a 55-year-old female, again, protrusion on the right side, you can see. The problem is not only bone grafting, it is again how to dislocate it and also generally in bad protrusion, you have to cut the neck, then you can extract the head like you are doing it for an echo femur or using a myo screw, and you can extract it. Or you can even, it is not possible, then you can go in and ream over the head like you are doing for a ankylosed hip. Because if you try to manipulate like you do normally in protrusion, you can have a fracture of the femoral side. So again, similar, this patient also had a GT avulsion, which again we wired it, and you can see the nice bone grafting. This is bilateral hip disease, simple case where you can have a gross, the loss of joint space. But if you look at carefully, this patient is having severe osteoporosis, so cannot see anything there. So that is another issue. So we had when we were, and this is one of the latest ones. So this was an uncemented stem which was used. So we had a fracture when we are trying to bang it in. So identifying these kind of fractures is always there. So uncemented stems, I will say, has got high chance of drop fractures, and we have to identify it. So for getting the press, we might go in and bang it a little bit more and have this fracture. So you have to be very careful. So cemented, I prefer to do a cemented stem and then uncemented cup. But the trend nowadays is more towards uncemented cup and steps. Thank you.
Thank you, Dr. John. That was very informative and elaborate. And we'll go on to the last talk, none other than Dr. Harish from Trivandrum, Senior Consultant in Cosmopolitan Hospital. He has a fellowship in arthroscopy and arthroplasty from Rizzoli Institute. He's also had his fellowship of ISACOS, and he has specialized in sports medicine and shoulder surgery, and also had a fellowship from SGH Hospital, Singapore. Over to Harish, and he will be talking on total knee arthroplasty in RA. Harish. Hello. Harish,
Hello,
you
sir.
are-
You're audible, sir.
Harish, you please unmute.
Yeah. Am I audible now?
Yeah. Now only.
Yeah, okay. I guess I'm the last man speaking. Thanks to KOA for inviting me and on the talk on considerations in rheumatoid arthritis and total knee arthroplasty. A lot of my talk also will overlap with Vinod. So not able to. Yeah. Okay. So approximately 20-25% of the afflicted individuals developed advanced arthritis despite.
Harish.
Yeah. Am I audible?
No, presentation is not open.
It's open on my.
No. It is just your desktop. That folder is on yours.
Is it okay now?
No.
Yeah.
Yeah.
It's okay now.
It's okay
Can
now.
I just do the slideshow?
Okay now.
No. Yeah. Right. Introduction.
Okay. Am I audible?
Yeah.
Yeah. Approximately 20-25% of afflicted individuals develop advanced arthritis despite immune therapy. So you need to know the disease is quite severe. So you need to have a good preoperative, intraoperative, and a postoperative planning for a successful outcome. Your preoperative considerations already discussed by Vinod. You need to have a good communication with your orthopedician and the rheumatologist, as well as screen the patient really well, especially the cervical spine in case of an anesthesia, especially with GA. And also you're dealing with comparatively younger patients between 40 and 59 years. So your infection and aseptic loosening to polythene wear will continue to rise, even more challenging in already complicated population. The polyarticular nature of the disease is further challenging. So overall prognosis is exponentially worsened, especially with hip and knee synovitis. So in patients with ipsilateral affected hip and knee joints with end stage arthritis, a total hip arthroplasty is first performed prior to the TKA. Controversy, like Dr. Patmanavan said, exists on whether the upper or the lower extremity pathology should be addressed first. So in case you have a RA of the shoulder, and probably if the patient is not able to ambulate, so you need to discuss or rather think which joint you need to replace first. A quick look at the perioperative medical management, that's in terms of a surgeon kind of thing. So any COX-1 or COX inhibitors increase bleeding risks and should be withheld before surgery. COX-2, like a celecoxib, is quite good, prescribed post-operatively. Steroids to treat flares of the disease and maintenance medications. And as we all know, the steroid usage causes poor bone quality and compromised immune wound healing, as well as rates of joint infection. And with the advent of the disease-modifying drugs, they delay the prevent end-stage disease. Now, this is what we need to know, that before we start surgery, that if it's the disease-modifying drugs, especially methotrexate, you preoperative phase, you can hold the drug, you don't need to discontinue. Post-operative also, you can restart. But with the other drugs like sulfasalazine and the TNF drugs, you need to withhold these drugs before you start your surgery. Intraoperatively, you're dealing with inferior bone quality and soft tissues. So you have a poor subchondral bone substrate. So you have osteopenia. So that can cause decreased implant longevity and forms bone cysts. So, and you need to deal with bone cysts. Like small cysts can be dealt with cement, but larger ones require either autografts or moss from the head allografts. That's a cyst that we're talking about. And also you're dealing with ligament laxities and joint deformities. So when you have gross ligament laxities, they cause increased constraint in the person. So what happens is obviously you're dealing with constrained implants. You'll have either femoral stems or tibial stems that's required. But with the advanced medical management, your mid-coronal plane deformities are a bit less these days, but however, your fixed valgus and the fixed flexion contractures are always present. So as you start your surgery, an essential important component of reconstruction is a full joint synovectomy, which is very important. So that you can lessen the inflammatory process, but you also need to preserve the fatty tissues to prevent scarring and adhesions. The use of cruciate retaining versus a posterior stabilized is still controversial. Although excellent results have been reported with CR processes, some concerns about the late instability due to PCL attenuation is there. That's the advantages of the cruciate retaining and a posterior stabilized. So cruciate retaining is inherent stability, less load between bone and cement, improved proprioception, improved kinematics, more bone preservations, whereas posterior stabilized is easier ligament balancing, better knee flexions, and lower range of axial rotation condyle translations. Some studies show that intraoperatively, as you need to assess the PCL before you decide whether you want to go with the CR or a PS process. That's a good article to read on for youngsters who basically just want to know exactly whether a CR or a PS is required for a total knee arthroplasty. Next discussion is about mobile bearing versus fixed bearing. The initial articles were suggesting a high rate of complications and high revision rates were detected in mobile bearing processes. But gradually now we have the recent articles in 2021-22 with the meta-analysis over 10 years suggest that mobile bearing designs have advantages over the fixed bearing designs. Although there's no clear consensus regarding the range of motion values or complication rates or mean scores. That's a recent article with the European Journal of Orthopedics, which they say is that current level of evidence demonstrates that both mobile bearing and fixed designs achieved excellent outcomes. So it's up to the surgeon with how you're trained, whether trained with a mobile bearing or a fixed process, and you can decide what's best for your patient. Specific challenges in RA, your goals is to correct the deformity, mobile and stable knee, alleviate the pain, and restore function and improve quality. That's the coronal plane deformities that you normally come across, a varus or a valgus. The sagittal plane deformities are usually a flexion deformity or a hyperextension deformities. And then you have a combination of deformities, either with a varus with a flexion or a valgus with a flexion or a hyperextension deformity or a Windsep deformity. We'll partly speak only on valgus knees. So valgus knees and flexion deformities, especially in RA. So valgus knees are present in flexion or extension or both, correctable or fixed deformities. You need to assess the MCL status, and your choice of arthrotomy can either be a medial parapatellar approach or a Keblish approach. It's not a mirror image of the varus knee, so you usually land up with lateral femoral condyle hyperplasia. So you need to make sure your bone cuts are really good, and if you require additional substitutes, bone grafts, that needs to be addressed as well. And your lateral popliteal proximity also is very close. And whether you want to do a CR or a PS, it depends on your integrity of the PCL, but you need to keep your constrained implants available. Your sequence for a valgus release is usually an osteophyte removal, a lateral capsule release from the tibia, a lateral patellofemoral ligament, iliotibial band at the level of the joint, or cleatus if required, LCL from the femur, intermuscular septum, PCL, and lastly posterior capsule and lateral head of the gastrocnemius. So for moderate 10 to 20 degrees of valgus where your IT band and posterolateral capsules are tight, you need to release them, pie crusting, preliminary bone cuts. And a PCL, if the integrity is good, you can go with the CR, otherwise a PS design is recommended. For deformities greater than 20 degrees where lateral collateral ligament is tight, a femoral side release or a lateral epicondylar osteotomy is recommended. Some cases, lateral head of gastrocnemius muscle release is required, but operative tendon is strongly discouraged. Regarding fixed flexion deformities, common occurrence associated with varus often, but gross deformities seen in rheumatoids also. Complete correction is necessary. people don't tolerate flexion deformities. Pathophysiology is more with the posterior femoral condyle, posterior soft tissue contractures and effusions preventing full extension and painful sternal muscle spasm. And your principles and planning should be a combination of soft tissue correction and judicious bone cuts. Constraint processes should be kept as a backup. So you have a CR, a PS, a PC3, or a rotating hinge. Keep an alternative plan ready. And if you have a flexion deformity of about 10 degrees, soft tissue release is all that is required, usually a posterior capsule or possibly a PCL or posterior ossifieds. But if it's between 10 and 30 degrees, then you need to consider a distal femoral resection up to 3 to 5 mm, a posterior capsule release, or a PCL resection to remove the posterior ossifieds. And for deformities greater than 30 degrees, you need to consider pre-upcasting and then a distal femoral resection of 5 mm posterior to build, you can reduce the posterior slope, a PCL resection, posterior ossifieds. Complications in terms of TKR and RA patients, risk of infection remains quite high, but 3 times more compared to OA. Surgical wound healing in cases of patients using corticosteroids or methotrexate, so your dosage should be relatively small. And regarding the DVT prophylaxis, they say previous studies have reported the incidence of DVT in patients undergoing hip and knee surgeries 3 to 10 times less than the OA. Reason being that decreased occurrence is because of the younger age of the patients and the frequent use of NSAIDs with antiplatelet activity. Thank you.
Thank you, Dr. Harish. We come to the end of our scientific sessions. Dr. Aneen?
Yes, sir.
Are we entertaining questions? Do we have any
not
questions?
Deblina,
Deblina?
I think. Anyway, what's the time now, sir?
It's around 9:30.
Okay.
Okay, shall we wind up the
Good time
session?
Anyway, all the speakers have been excellent.
Yeah.
Thank you all for sharing your experience and your knowledge.
Thank you. Special thanks to Dr. Bimal, who has coordinated the surgical talks, and Dr. Vishad, who has coordinated the rheumatological medical talks. And I thank the OASIS for giving the KOA this opportunity. Thank you, Dr. Aneen. Thanks to Professor Selvaraj, and thanks to all the team involved. Thank you all.
Yeah. Thank you all the faculty. Thank you
all
very
the-
much, sir.
Yeah, thank you. Good night.
Good night.
Bye-bye.
Good night. Good night. Excellent talk, Vishal.
Yeah, Binoy.
Harish,
please.
everybody.
Yeah, thank you.
John. Good night.